Good morning, everyone. So, we are here for Indian Arthroscopy Society IS1 CME in workshop. We'll start with the meniscus session. So, moderator is Dr. Ravi Kumar. Ravi Kumar, can you please?
Good morning all, warm welcome to all. May I call the chairperson Dr. Subhash Chandra. Dr. Subhash Chandra sir, please come. Dr. Praveen Sahu sir, Dr. Rakesh Chaudhary sir, Dr. Sunit Hazara sir and Dr. Avinash Kumar sir, please welcome to the stage sir. I Dr. S.P. Gupta sir, please. So starting with our meniscus session, may I call Dr. Gurdev sir for his first topic, discoid meniscus tear. Gurdev sir, please warm welcome to you.
Good morning, everybody. My topic of presentation is discoid meniscus. As we all of us know, the discoid meniscus is most of the time the incidental finding while we are doing arthroscopy for some other procedure. So it is considered as a synonymous with the snapping knee syndrome. Its incidence varies from 0.4 to 17% in the mostly in the lateral meniscus. The medial side is the very rare. It is only hardly 0.2 to 0.3%, and it is very much common in the Asian population in the female group. And the bilateral side involvement is 15 to 25% of cases. Then the classification, the Watanabe who had classified mostly in the lateral meniscus. The medial side is the very rare. It is only hardly 0.2 to 0.3%. And it is very much common in the Asian population. In the female, there is something wrong. Okay. Oh, sorry for the inconvenience. Then the Watanabe who had classified the discoid meniscus into three types. Type 1 is the complete type where the lateral meniscus is abnormally thick and it is the complete coverage of the lateral tibial plateau by the meniscus. And there is normal meniscus attachment on the posterior side. Type 2, the incomplete variety, it is semi-lunar in shape and it's only cover the 80% of the lateral tibial plateau and there is normal posterior attachment. And type 3, that is the wristband type, it's a normal or almost normal meniscus with normal thickness and there is lack of usual posterior meniscal attachment. So the function of the meniscus is why it is important to conserve that meniscus, because it helps for the joint congruity, lubrication, joint nutrition, shock absorption, joint stability, joint transmission and the stress reduction between the joint. So the anatomical changes, how it differs from the normal meniscus to the discoid meniscus. It is thicker, there is more surface area, less vascularity of the peripheral side than the normal meniscus. A reduced number of collagen fiber with more disorganized coarse intrameniscal liquid degeneration most of the time in the body part. So the diagnosis comes to the clinical, it depends on the age, type and tear and the instability pattern. Mostly it is asymptomatic and sometimes the patient presents with a snapping knee syndrome and the mechanical symptom like locking, pain, not able to fully extend his knee, on examination there is clunk, snapping or the extension deficit. The diagnosis, the X-ray gives the many of the clue about the discoid meniscus. Here on the X-ray you can see here there is a squaring of the lateral femoral condyle, cupping of the lateral tibial plateau, widening of the lateral joint a space up to 11 mm, and of course there is hypoplastic lateral tibial spine. The MRI which confirm this diagnosis in the transverse meniscus diameter is more than or equal to 15 mm between the free margin and the periphery of the body on the coronal view. And there is continuity between the three consecutive sagittal slides. Both you can see the anterior and posterior heart, then definitely the signal comes in the mind there is a discoid meniscus. And the coronal image saw there is thick and flat meniscus tissue extending across the entire lateral compartment. So the treatment, most of the time it is treated as a conservative, because these are just the incidental finding with no symptom and no physical sign. Only patient presents with a snapping knee with no other symptom. But sometimes socialization or the repair is needed when there is the symptom or the reduced range of movement, pain, like that. And what we do in the socialization, we just remove the meniscal central part, keeping the periphery up to 8 mm intact in adult population, and in the children at approximately 6 mm. So this is the quick video, can just to demonstrate how to do socialization. So this is the complete variety of the discoid lateral meniscus in a 12-year young child. Little bit it is a hectic process, we have to keep patience, use the straight punch, backbiter, saver, radio frequency and the probe. Simultaneously probing, cutting with the punch, and at the same time you use the probe to check the leaflet, the superior and the inferior leaflet. And mostly in this type of the discoid meniscus there is degeneration, interstitial degeneration in the body part. So we have to check all the time with the probe between the leaflet, then suck the debris with the saver, and for the anterior part it is very difficult to use that biter. So in that situation we use the 18 gauge spinal needle multiple perforation to debulk the tissue, and for the experienced surgeon he can use the 11 number knife also to just cut it transversely and then use the saver blade or the punch. And sometimes we have to create the far more medial portal in the figure 4 position, so we can hit the anterior part from the far 4 medial portal. If the thickness of this discoid part is reliable, then we can just close this leaflet with the scorpion. But sometimes if the thickness is too much, then you have to remove one of the leaflet with the punch and do it the balancing of the meniscus. Here we just create the crescent separate of the meniscus and remove the upper leaflet with the punch and the gradual shaving. And we think on that time it's okay, so I leave it as such without any repair of this kind of discoid lateral meniscus. This is the final picture after the saucerization. This is one case of 17-year-old male patient having trivial trauma on the right knee, and there is pain on the lateral side of the knee. He is not able to extend his knee since last 1 year. Blackman and the anterior trauma test grade 2 positive, pivot shaft negative. On the MRI, there is partial tear of the ACL, and of course there is complete lateral discoid meniscus with mucoid degeneration. These are the MRI findings. But once I put the scope in his knee, then you can see here this is just incomplete variety of the lateral discoid meniscus. So here we just do the saucerization and simultaneously do the repair, marginal repair of the saucerized part. The video quality is not so good. Thank you.
Discussion at the last video.
Yeah. Anyone want to ask question? Yes, Dr. Manish.
How often do you go for because when you're doing a saucerization for discoid meniscus, you ultimately create a horizontal cleavage, a sort of horizontal tear in the meniscus. Do you go for repair or we can leave it as such?
Nowadays it is mandatory for me. Almost I do repair in all the cases, because if we are leaving that both the leaflet superior and inferior is just like a fish mouth appearance. There is a gradual seepage of the joint fluid, and it leads to the later on the parameniscal cyst, and definitely the patient have the pain and the symptom like that. So and another thing, these meniscus are not the healthy meniscus. Here the collagen fiber is not normal as compared to the normal meniscus. So it is recommended to repair close the mouth of that leaflet with the sponge.
One more question, if possible. This question can be to the entire house. Miss, what should be my limit of saucerization? How much to leave?
In an adult population, we have to leave at such as little as 8 mm of the periphery, and in the young child up to 10 years or the 12 years, it is recommended the 6 mm is okay.
And what are the complications you get after the surgery? Again, there is recurrence of leaking sensation or not?
No, previously what we have did, we just do the saucerization, because on that time we have the learning curve. We are not going to repair such kind of tear, such kind of lateral discoid meniscus. But till now I did not have encountered any kind of post-operative complication. Maybe patient have not reported to me, but right nowadays we have to go for repair all kind of this kind of lateral meniscus after saucerization.
So after repair you get very less complications.
Yes, definitely.
Thank you.
Dr. Good, basically in discoid meniscus it's horizontal component also. At the same time there is separation of meniscus from the capsule level. Okay, it's come completely inside the joint.
Yes.
So what are your tips for repairing that peripheral part of the meniscus to the capsule? And because the chances of a failure of repair of discoid meniscus is very high.
Yes.
So what are your tips and tricks for repairing? Because nowadays the meniscectomy incidence is decreasing day by day. At the same time, repair is incidence is increasing day by day. So horizontal part is good. You just take the circumferential stitch or mock closing all inside device. It's good, no problem. But the problem is started when there is separation of the discoid meniscus from the capsular side. And in most of the cases it is there. In some part it may be partial, in some cases it may be complete. In fact, mostly cases it's almost complete. That's why the initial treatment of discoid meniscus is almost subtotal or total meniscectomy, because there is hardly any attachment of the capsule and the meniscus. So what is your tips to prevent the failure of meniscus in discoid peripheral meniscus?
Yesterday I was doing one live surgery, and what we have shown on that case, maybe the things like the same. The posterior part is hypermobile. The posterior aspect of the lateral meniscus attached to the capsule is too much mobile. You can just probe and it is coming out like that. So I just leave it on that. These cases I just leave it as such. But in the discoid meniscus, many of times there is hypermobility and there is peripheral tear. So in the most posterior part, I use the all-inside device to repair that part. But comes to the body and towards the anterior, I believe on inside-out technique repair of that kind of meniscus.
Yeah, but I slightly differ from what you said. I think my findings is when the meniscus shape is intact and it's a type 3 where the hypermobile, then the meniscus shape is usually intact, maybe a little more larger than that. But by and large, the classical, the video which Gurudev was shown is probably type 1 or type 2. And type 1 and type 2, it's already there in literature as well. कि वहाँ पे peripheral tear नहीं रहता है, capsular attachments are intact in type 1 and type 2. It's only the type 3 Risberg type जहाँ पे मतलब the hypermobility is an issue. And I really, I mean, it's a natural thing. So the edges are very soft, smooth. So the chances of healing is less. So you need to spend a lot of time preparing those, and बढ़िया से prepare करके बस repair करना ही मतलब is what we can achieve. Right? I think how good the meniscus will heal, it's very difficult. Certainly the chances of failure is high, but I think you have to repair it, and you have to spend more time preparing those repairs.
Yeah, absolutely right. But what we get, the symptomatic patient, that is mostly type 3 type of.
Exactly, because of
Thank you.
yeah.
Excuse me. What in the past it was a trend that in the sportsmen we used to get horizontal tear of the meniscus, but it was left as such because there was a saying, let the sleeping lion sleep. Now, you said that there is a fear of getting parameniscal cyst and all. So, do you get in every horizontal tear degenerative in sportsman who has been playing a lot in badminton and any tennis? And maybe what is the trend recently?
Sir, the horizontal meniscus tears, we are not also going to repair all the time. But horizontal cleavage tear, in that situation we have to go for repair. But again, the civilian population and the sportsman. A sportsman, he had a very limited time of career. If suppose we go for repair of that horizontal cleavage tear, he has to away from the field for at least 3, 4, 5, 6 months. And he has spoiled his career during that that time. So it is better to remove that part and do rehab and go to allow him to go to the field. Early rehab. Yes.
So it differs from person.
Yes,
to person.
it differs from the normal population.
And as the profession.
Yes.
Next speaker, Dr. Ritvik Ganguly.
Thank you, sir. Thank you.
Now Dr. Rajiv Ranjan will be. Sorry. Ritvik.
So is basically a pleasure for me to present something which is really done, because it was done previously, and because of that undetected nature of meniscus root injuries and untreated cases, we have come across such scenario in young age. The 43 years male patient, history of root tear. It was previously treated with meniscectomy because there was no option available at that time. The meniscus repair system was not there, and the root tear was treated, and the end result is this after 5 years down the line. So what is the root? The root is basically the attachment of the meniscus at the tibia by anterior and posterior part. In front is the anterior and posterior root, and most injuries, the posterior root injury is common, much more common than the anterior root injury. The tear of the meniscus root has been reported in 10 to 21% cases of all meniscus tear. So definitely it is underdetected. And these injuries undiagnosed at the initial presentation and to contribute to the degenerative joint disease. Posterior root tears has been associated with the patient having higher grade of osteoarthritis, venous or valgus deformity depending on the site of the tear. But mostly these injuries are on the medial side, and it is seen in the older individual, female, obese patient and low energy. During squatting posture, there is typically the pop sound at the back of the knee, and after that patient complains of pain and swelling immediately. So this signifies there is something is torn at the back of the knee, and it is the torn posterior root. So it is also associated with ACL injuries. The biomechanics is that the ACL is a primary stabilizer against the anterior tibial translation, and the lateral meniscus posterior root has been reported by biomechanical study to serve as a secondary stabilizer of anterior tibial translation during pivoting in the ACL deficit knee. So lateral meniscus tear demonstrated to increase the tension of the ACL graft in ACL reconstruction. So if the patient having ACL tear with the root tear, if you done the only ACL reconstruction, then there is a high chance of failure due to the increased tension of the graft. And the high incidence of meniscus root injury both in the primary and in the revision scenario. The incidence of lateral meniscus posterior root tear is 4 times more than the medial side in both primary and revision subset. The recent finding is that ACL graft forces an increase in setting of posterior meniscus tears, and meniscus root repair restores the graft forces to normal when compared to the intact side. Diagnosis is challenged because the clinical findings is not that, because the patients are obese patient, already some arthritis has been there, the joint line tenderness is marked, but it is more on the posterior aspect, and the other test is almost equivocal. The MRI also is not saying the perfect, the sensitivity and specificity is not that like the ACL injury or the body tear or anterior tear. The lateral tear associated with the trauma and sports injury, unlike the medial tear, and most patients with the medial root tear is not able to recall the injury, and patient may or may not having had associated pop. The pain occasional with the passive range of motion, deep flexion, squatting is painful, but this is very important to note that a grade 3 latchman with grade 3 pivot during physical examination should raise the suspicion of combined ACL and lateral meniscus root tear. So the MRI is not foolproof. It is only 73% sensitivity and 77% of sensitivity of 77 and specificity of 73. Some other signs are like meniscus extrusion is very important on the coronal image, and the fluid around the tear. The radial tear adjacent to the meniscus root can be observed as linear areas of high intensity perpendicular to the meniscus. the vertical line defects at the meniscus root itself is referred to as a truncation signs, and these along with the growth sign have all been reported to have high reproducibility, sensitivity and specificity. This is a classification system. Generally there are 5 types by Rob Lampard classification. The type 1 is partial, type 2 is bit common, it is complete and near the root. Type 3 is disaster because along with root tear there is a component of bucket handle. The type 4 is oblique type which has propagated to the root, and type of 5 is the avulsion, bony avulsion. Fixation method either by suture anchor or pull-out stitches. Suture anchor can be done from the for medial meniscus, posteromedial portal suture anchor, but it is not really done. It is rarely done nowadays. The pull-out technique is commonly done because of its more tensile strength and is a less chances of failure. So these are the techniques of the pull-out technique of meniscus repair. I am coming to detail with the video. It is not working. I can show the video from the folder. So this is the medial side of the knee. So always probe the meniscus. Probing is very essential in the posterior part in a primary or a revision setting. Receives the posterior root is torn. Then we have to debride the base of the meniscus for good repair. Then after that we can see where the meniscus can be seated. Freshening of the bed is very important because if you don't freshen it, then it leads to the failure and not proper healing. So after that you have to take a bite from the either use of the scorpion or the any other suture shuttle device. Then the tibial tunnel at the footprint is done. It can be done with the help of 2 tunnel or single tunnel. In case of 2 tunnel, there is no need to use the hardware. It can be tied in front of the tibia with the help of these bony bridges. But in single tunnel technique, it should be tied with the help of these suture discs or intervertebral. So it is this drilled with 5 mm drill bit. Then after that the suture settling is done. And the root is repaired. So this is all about root repair. So probe all the root whenever you are entering in the joint, whether it will be lateral root, medial root, so that it should not be missed. Thank you.
Any questions?
That was a very good demonstration of root repair. What has been your experience of type 3 compared to 4 and 5, where you have a root tear along with a slit in the pocket hand? Yeah, pocket hand.
So it is a disaster. So as the name signifies, it is a disaster.
Yeah.
So you have to take care of the both part. You have to take care of the bucket handle part. You have to take care of the root part.
my experience has been that in that cases I haven't done many, so I can't say it's massive experience, but I have to remove almost all of the meniscus, because if you remove half, it defunctions the rest half. Whereas 4 and 5 repair is easier, and
Yes.
you can get a good stable repair.
So
But
in
three,
most
I
of the
haven't come
cases, the
across
bucket
many.
handle, the inner part is, if there is a white part, white zone, then you can remove it. Okay, and remove, and you have to stitch the peripheral part with the pull-out technique. The remaining part, it may not be that much of stout, that much of quantity, but you have to fix it. If it is a peripheral tear, if it is a peripheral tear with the root, then you have to repair the peripheral tear along with the root.
But along with that peripheral small part, you have to repair it to the capsule as well to make
Yes.
sure it is stable.
Yes.
But it still leaves very thin rim, and you are always
Yes,
in doubt
absolutely.
whether it will re-tear or what will happen.
Absolutely, chances are very high. So that is why the name.
Yeah. Thank you.
Excellent discussion.
Yes.
About the anatomical placement of the root. So, how you decide about the lateral meniscus and how you decide about the medial meniscus intraoperatively? Because a couple of studies says even if you repair medial meniscus root or lateral meniscus root, but if it's non-anatomic, then it's hardly helpful in the long term.
See, most of the cases, the fresh cases are easy to find, because whenever you are first you have to see where the meniscus is sitting without any tension. So tensionless repair is important, and the meniscus root is in between the tibial PCL attachment and the ACL attachment. So you can see, and always if there is any query, always get posteromedial port to see it is just behind the ACL footprint. So that's why you can judge intraoperatively from the front and from the back with the help of posteromedial portal the proper anatomical landmarks.
So a message is the anatomical repair that is important for the root.
Yeah, of course, there is no doubt. But sometimes in chronic situation, it really becomes very difficult to bring the meniscus to the main where the anatomical site. So I think probably if you can't repair it anatomically, it's probably you might end up with some non-anatomic whatever best is possible after releasing the meniscotibial ligament and everything. So tension-free repair is also very important, because ultimately root has to heal to function. So healing is more important, robust repair is more important. In chronic situations, sometimes you might have to compromise on the exact site.
Yeah, absolutely right. You have to release the meniscus from the capsule, that is iatrogenic wrap you have to create, and it's the anatomical reduction is more important, and it should be tension.
Sandeep, your opinion on this, and do you have any difference of opinion repairing the medial and lateral root? I mean, in chronic situations where you cannot bring the root to the anatomical site, what you do, and
So, if we cannot bring root to the anatomic situation, so best would be to get good approximation of the root. I mean, whatever is left of the body and part of the meniscus with the good capsular fixation, and you can still try and see if you can approximate, if it is possible for you to, or you can just treat like a meniscus extrusion.
Yes, the meniscus extrusion is the main thing, so that the hook stress will be less. So a meniscus fixation, if there is a peripheral tear also, if there is a root cannot be seen, we have also done with the help of suture anchor at the peripheral part of the tibia. With the help of the suture anchor, we have taken the bites and we repair.
So most of the times, if you're seeing that the root isn't coming to the anatomic location in chronic cases, we would have always done a scanogram and check the alignment. It's rarely seen that a patient has no constitutional varus, has no varus deformity post-arthritis, and has a chronic root repair that's extruded and that's not reducing. In that odd scenario, where you're not going to offer an alignment surgery, you need to release the capsule as far as possible. So a good way to do it is, it's like creating a ramp lesion. So you try and open up the capsule, if possible, through the posteromedial portal with scissors and create a ramp lesion. If you create a tear in the capsule there, then the meniscus becomes a little more mobile. Having said all of that, we don't know once we try and fix it to the anatomic location, if again it takes all the stresses or not and it functions nicely. But it just makes you feel good as a surgeon.
Dr. Manish.
If you are creating a release of the meniscus from posterior, just like he said, you create a ramp lesion hydrogenically and try to approximate the meniscus to its anatomical position. Do you feel that would be good enough, or that is going to lead to further complication later on? That has to be taken.
See, if the thing is that the repair should be tensionless.
That's right.
The tensionless repair. If it puts maximum amount of tension, then there is a chance of failure. And if you create a ramp lesion, then after root repair, if it is mobile kind of thing, you have to yes, you have to get a more problem, and then you have to repair it by all inside or other means.
Not to the house. Is there any cutoff time frame where you should not try to struggle to bring the meniscus to its anatomical position? Is there any cutoff time frame? Beyond that, you should not go for it, and just leave it where it can sit and repair there itself.
I don't think there is any time frame. I think it all depends on a lot of relative situations. Like we know that the meniscus, medial meniscus roots are mainly degenerative tears. The traumatic tears are on the lateral side. So we are a little more aggressive towards treating the lateral meniscus roots than the medial meniscus. If you have some various and everything, you know that already the arthritic changes are going on. There are lots of paper which say that you don't need to repair the meniscus. You treat the arthritis by doing the HTO or something like that. So I think it's not the time that is important. We are more aggressive towards the lateral meniscus root, traumatic root, and we want to bring the root to a function as much as possible.
Some of the studies they are saying that after a period of around 3 months, the fibers within the meniscus that undergoes lots of contraction or shrinkage. So it's very difficult to bring it to the anatomical position. So a 3 months cutoff time frame has been given, so that you should not struggle much beyond that.
Yes, it depends on lots of factors like age of the patient, the activity level of the patient, the duration itself is not that, yes, it is important for repair and healing and all, but these things should be kept in mind also. Because in young athletes with the ACL tear and all, if we see it's a old tear, then you have to fix it.
Great. I think we should stop here, and there is in the next discussion. Thank you, Dr. Ganguly, for flying early morning, taking the pain of flying early morning to us, and excellent presentation.
Very good photographs.
And the video of arthroscopy you showed, which was very clear, and it was easy to understand. Thank you.
The next speaker, Dr. Rajiv Ranjan.
Dr. Rajiv is doing arthroscopy at PARAS Hospital.
Good morning, everyone. So I will be talking on this ramp lesion. So what comes first in our mind if we just listen to ramp, the ramp walk? But what we deal with is not that glamorous. This is just this boring ramp which we see in the posterior part of the medial tibial condyle, where the posterior horn of medial meniscus, the attachment goes slightly down towards the posterior medial capsule. When there is a lesion, it's a longitudinal, vertical or oblique tears affecting the posterior horn of the medial meniscus. It may lead to the meniscocapsular or meniscotibial disruption. Around 40% of all ACL tear patients have been reported to have an associated lateral or medial meniscal injury. Strobel in 1988 has described this type of injury, and which is now known as ramp lesion. The incidence varies from literature to literature, but it's around 10 to 20% in majority of the literature does incidence of this ramp lesion. These lesions can cause pain, dysfunction and alteration in the knee kinematics. The lateral meniscus tear occurs slightly more frequently, around 56%, and the medial less, the 44%. In acute, associated with the acute ACL injuries. However, in the chronic ACL injuries, the medial meniscus tears are more common. The prevalence of this ramp lesion significantly increases with the passage of time until the 24 months up to the 2 years, and after that it gradually plateaued, which shows that the intervention should be at the earliest possible time. And this ramp lesions are, they cause the increase in the force on the ACL, and it also increases the rotatory instability of the knee. They increase this anterior and external rotation instabilities are not restored if we do isolated ACLR when these are associated, until unless you combinedly repair this posterior meniscocapsular repair. So what are the significant risk factors where you have to think about the possibility of presence of this ramp repair lesion? Is the bony contusion in the MRI at the posterior medial tibial plateau, and the chronic ACL injury like we have seen up to the 2 years, the incidence gradually keep on increasing. And then the steeper medial tibial or meniscal slope, gradual lateral tibial slope, and the varus at the knee more than 3 degrees. So MRI, it's difficult to diagnose MRI, this ramp on the MRI, because what we do the MRI in the extension position of the knee, at this position this ramp repair lesion reduces itself. That's why it becomes difficult to diagnose. The most specific sign which we can see on the MRI is the presence of the thin fluid signal interposed between the posterior horn of the medial meniscus and the posterior medial capsule, and it's sometimes it becomes difficult to distinguish this from the meniscocapsular separation from the peripheral vertical tear of the posterior horn. These ramp lesions were present in approximately, in one of the literature it was also present in the 17%, and the sensitivity of the diagnosis was less than 50%, it was around 48%. Another thing which we have already seen, which can be a clue for the presence of this ramp lesion, is the posterior medial tibial bone bruise, which is a secondary sign and present in almost 72% of the patient. So what changes in the MRI can lead us to a better diagnosis, more specific diagnosis of the presence of this ramp lesion is the flexed knee or 3D sequence of the MRI. In this, we see the irregularity of the medial meniscus at the posterior margin, and there is a gross difference in the detection of these lesions at the 10 degree of the flexion of the knee and at the 90 degree of flexion of the knee. At the 90 degree of flexion of knee, the specificity and the sensitivity of the diagnosis of this ramp repair increases significantly. Another sign, the complete fluid filling sign, is also increases significantly at the 90 degree of flexion compared to the 10 degree flexion when the MRI is taken in that position. This 3D sequence is not available, I think, right now in Patna, but it is present in some centers of Delhi right now. This diagram depicts the normal anatomy where the posterior capsule and the meniscocapsular ligament, meniscotibial ligament, and the posterior horn of medial meniscus we can see. In the MRI also we can correlate with these anatomical structures. So it's a busy slide. This is classified by the Thorner et al. And the Brief et al. We will see one by one in the next slides. This type 1, where the meniscocapsular ligament tear is seen. The next one is the partial superior peripheral posterior meniscal cord tear. The whole term describes itself, it's the anatomical location and the type of tear. The type 3A, the partial inferior peripheral and posterior horn meniscal tear. 3B, the partial inferior affecting the meniscotibial ligament. 4A, it's a complete peripheral posterior horn meniscal tear. 4B is a complete meniscocapsular junction tear. And the 5 is the double tear. So repair techniques, inside outer all inside, commonly what we do is the all inside. For a smaller one and the stable one, the subacute or chronic injuries, we can go for conservative management by doing the abrasion and refination. In other cases, except the type 2 is considered as the stable one, in most of the other types we need to repair it if you want to get a better anterior translation and external rotation correction. So the all inside repair through a standard anterior portal with implantation of meniscal suture like what we use in the all inside repair. It's easier to do. What is done in this case, just a one bite through the posterior medial portal is taken in the posterior capsule, and then the thread is passed anteriorly, and we pull the thread and we keep the capsule reduced, and then we pass the all inside meniscus repair device like Fabry stitch, and we reduce it. But biomechanically this is not superior to the vertical sutures what we place by through all inside techniques, because that also creates a defect in the red white zone in the meniscus, because we are going from the anterior towards the posterior side, that if we are using these devices or the all inside technique. So it's always better to go for the vertical repair. The posterior medial portal is met by this transillumination sign and going posterior to the saphenous vessels. This is the trans-notch view. The medial femoral condyle, the PCL and the tibia. Through this, the scope is in our anterolateral portal, and through this we go behind the knee joint and we see the posterior part of the knee. The best device which we use is the 25-degree suture hook, the lasso. The left direction we use in the right knee, and the right direction we use in the left knee. This is one of the case of Dr. Arvind. So what we have seen, this is a double type. Yes, we can see the medial meniscus, the torn part of the posterior horn of the medial meniscus, and the meniscocapsular junction tear. The lasso has come out from the posterior medial portal, and the bite has been taken. This is type 5, the double tear type what we have seen. The lasso has come, the bite has been, the bite is taken in the meniscocapsular part, then in the meniscotibial part, and then we go through the meniscal part. Shuttle device is passed, and then the 2-0 fiber wire is passed over that shuttle device. Next one. Fiber wire is shuttle, and the sliding knot is taken, which is reinforced by the 3 half inches alternate. And this is one of my cases. It shows the type 4 tear, in which I kept this just to show how to make that posterior medial portal. This is a tear. I will see more clear later on. This is the meniscocapsular type 4 tear. the needle had been passed on the posterior medial side, and then it has been enlarged, and then the shaver freshened the ends of the tear. The tear has been probed, and then the repair has been established. This was a case which was associated with a large tear of the body of the lateral meniscus and associated with the ACL tear. This case was 5-year-old ACL tear. So gradually it kept on increasing the ramp and then the body of the meniscus. Thank you.
Thank you. So, I think because of shortage time, probably we'll have next speaker. So may I now invite Dr. Sandeep Biradi, who is the secretary of the. Sorry. Now we have Dr. Arvind Gupta. He will speak on double bulkhead handle tier 3 life surgery. He always keep the difficult thing for himself.
So, bucket handle common is maybe mostly we have seen by regular interval, but many a times it's the double bucket handle, which once you are inside the joint and you feel it's double bucket handle. So this is 22-year male, 8-week-old injury it is, with 20 degree of knee flexion deformity is there, and X-ray was within normal limit. So Ratan is here. So Ratan, what comes in your mind with 8-week-old injury with 20 degree of the knee flexion deformity and X-ray is within normal limit? So Parimal, X-ray is normal, 8-week-old injury, 22-year male boy having 20 degree of knee flexion deformity, which is not getting corrected. So what next investigation you ask for? MRI, perfect. So this is the MRI of this patient. So what you can see in this view? So Vanshu?
Double PCL sign.
So double PCL sign. That is predictive of bucket handle tear. So this is double bucket handles, double PCL sign is there. At the same time you can see the posterior horn of the medial meniscus is hardly visible in this slide. And this is the coronal section of the MRI. Again on the medial side, you can see it's completely vacant. So diagnosis is confirmed. This is the bucket handle tear of the medial meniscus. And we are discussing the meniscus. So what are the main function of meniscus? It's basically convert the stresses that any person get when he get a stand, run, from the vertical stress to the hoop stress, like this. So stress coming to the knee joint and this get converted to the hoop stress, so that the point contact get decreases and the stress get completely transferred all over the joint. This is the function of the meniscus. So this was the intro picture. So this patient was having ACL tear also, and this was the, you can see here, you can see there is one tear there also. You can see here the double bucket handle is there, and this is the 8-week. And the reduction is a little bit difficult. And this is the remaining peripheral part. So Sunit boss, 8-week-old injury, this is the quality of tissue with 22-year male boy, associated ACL tear is there.
Yeah, I think, there is no doubt that this efforts will be made to repair it, but it's a very large bucket handle. We know the prognosis is not good, and that too you have a double bucket and between the tear also. So I think I will explain the patient that the chances of healing is less, but the efforts should be made to repair it, and then go ahead and watch the patient based on serial MRI. And if it
One
heals,
is for repair or resection?
I'll go for
Abhishek was 22 years.
in 22-year-old, I'll make all efforts to repair it. Though
Ritik was?
prognosis may be good.
Sandeep was? So consensus is to repair the meniscus because the 22-year male boy, in spite of double bucket handle, quality is little bit compromised, but associated ligamentous injury he had. That is one of the positive things in this case. Associated ACL tear will give you the better joint opening. At the same time, the healing potential is also high because you are making tunnel in the femur and the tibia. So this gives lots of the growth factor inside the knee joint. So environment for the healing is good. So I also plan for the repair, and this is the preparation of the bed. So after this preparation, the medial compartment is compromised, very less. So by doing gradual pie crusting, you can see how this medial compartment is getting opened. So while doing the repair of medial meniscus, always keep in mind that you should not damage the cartilage because of very less space. And by doing the gradual pie crusting, you can increase the space. Then you reduce this. You can see there is a small tear is also, so you can see almost triple bucket handle type of thing is there. Once it gets reduced, so I change the portal from the being portal from anterolateral to the enteromedial, and my cannula for the repair is coming from the anterolateral side, so that it's face at the 90° to the capsule and the meniscus. So this is the inside out meniscus repair system, which is taken as the one of the gold standard for the meniscus repair. So this is here for the tractional stitch, so that meniscus should be at reduced position. One this meniscus stitch is there from inside out, and we have created enough space by doing gradual pie crusting. One stitch is there, so that now my assistant is keep holding this traction stitch so that this meniscus is remain stable there. After putting one, there is little bit still there is subluxation of the meniscus, so another stitch again for keeping it is in place. And once two stitches there, then on the posteromedial side, or almost on the posterior side of the meniscus, this is all inside device. Repair of this all inside device, the posterior part of the meniscus, because here inside out technique is little bit dangerous, and if you want to do, you have to create the incision and keep the spoon, take the needle out, so this must become little bit lengthy. So by putting all inside devices become stable. So again from the lateral portal, that is the working portal, again my cannula is here, another stitch. And then again this is the fourth one. Interval is usually 4 mm. What Dr. Sunit was, what you suggest?
Yeah, but it's very difficult to measure the 4 mm.
Yeah, but it becomes very difficult. So sometimes you may be very close. That's happened in this case also. These two stitches are little bit closer. You can see these two stitches are little bit closer, but ideally it should be at 4 mm. Then again there is, can see here another stitch, one through the capsule, one through the body, and you can see there is a small cleavage is here also. So once peripheral part gets stabilized, and then this part is in white zone, so the meniscectomy of this part was planned, this part get resected. So Sunit Bas, you can tell me if I am doing anything wrong here.
चार्ली ब्राउन के पास बात तो आप ही को देख रहे हो, इतना सारा सुचारू करते हो.
So this part get resected, and in the interior 1/3 part, putting this inside out cannula becomes sometimes difficult. So again I change my cannula from anteromedial. Here after doing this, there is horizontal tear was there. Mouth of the meniscus was open. So this was the circumferential type of stitch to close the mouth of the horizontal part of the meniscus, and this is in the posterior part, body part, and this is quite stable meniscus now in the posterior part and the body part. Here, here you can see the cleavage in the anterior 1/3. So for this part, I do outside in technique. So with the 18 gauge needle, this is the wire, the chia wire from the lasso. You can do by various needle also available in the market, but I feel well controlled with this. So by passing through this, one from the capsule, one from the body, just 1 minute, hardly 30 seconds. And then the ACL reconstruction at the same time. This is the ACL, and this is the fully repaired meniscus, the double bucket and the meniscus, which is fully repaired. 7 stitches inside out and 1 outside in, and 1 360 inside. Thank you.
Excellent presentation, Dr. Arvind. It was nicely demonstrated and done.
So I think live surgery is going on. So we can have Dr. Sandeep lecture after completion of this live surgery.
Yes.
Yeah. So moderator
No.
is for the live surgery is Sunit Bas, you stay here, and Dr. Abhishek Das.
Yeah, please, Dr. Abhishek, please join.
Thank you, as chairperson. Can we take the seats in the front?
Hello, am I audible?
Yes, sir, you are audible, but your voice.
Dr. Ritik Bas, please come on the dais to moderate the session.
So can somebody increase the voice of Deepak sir? थोड़ा बहुत. Hello.
And also, meanwhile, to save the time, Dr. Janki is felicitating all the chairperson.
Dr. Arvind, can we start?
Yes, sir. Please, you go ahead, sir.
So, a brief history about this case. First of all, thanks Arvind and the organizers for having me here. I am here along with my colleague Dr. Shiv. Now, coming to the history of this patient, he is 24-year-old male who got a road traffic accident of just about 7 days back, where he fell and he twisted his knee. Since then, he has been having episode of the buckling of the knees. And on examination, what we found was the Latchman test was positive, and there was medial joint line tenderness. So these were the only 2 findings. And on MRI, we could appreciate there was a ACL tear, but on the MRI, we couldn't find any meniscus tear. So now this is the diagnostic arthroscopy round. I'll take you through. Coming to the medial compartment first.
May I call upon stage Dr. Prabhat sir to felicitate Dr. Subhash Chandra sir.
Should we go ahead?
Yes, sir. In between, we are taking the time to save the time. We are felicitating the chairperson, but you can go ahead, sir, please.
Okay. So on the medial side, what we did while probing, we found that there is an undersurface meniscal tear. So what we have done is we have done the pipe testing so that we can open up the medial compartment and you can appreciate this is the tear. Can you appreciate?
Yes, sir.
So there is an undersurface tear, very small tear.
Yes.
But it has got some mobility. Can you appreciate that?
Yeah.
There is some mobility, so these undersurface tears, they might over a period of time convert into, full thickness. So we'll just be stabilizing it with two all-inside devices. So this is the plan for the medial side. Coming on to the intercondylar area, we have cleaned this area. This is the footprint of the ACL, you can see very well.
Yes.
This is the footprint on the tibial side, and again on the femoral side, I'll show you the footprint when we make these tunnels.
Okay.
Coming to the lateral side, can I have figure of 4 position? So we probe the whole of meniscus. Since it's a fresh case, there was a lot of bleeding.
Okay.
But just a minute, I'll show you. So lateral meniscus must be probed in its entire length, and very important is to probe the root area. We have already probed it, it was alright, but this is an area which is often missed. So you should not miss the root area of the lateral meniscus. Unless you try to raise it, sometimes you cannot appreciate the root.
Okay.
So now coming to so we'll make the tunnels first for the, now let me tell you that ACL is all about restoration of an artery. So this is the footprint of the ACL,
Yes,
and
sir.
this is for about 17 millimeters.
Okay.
So if you make a single tunnel somewhere here, even if it's of 9, it won't restore the full footprint. So
Okay.
what we'll be doing in this case is a double bundle ACL reconstruction.
So can you once again show the anatomical landmark for the tibial insertion?
Yeah, this is the tibial insertion, and the TL would be, this is the meniscus, lateral meniscus anterior horn.
Yeah.
So this is the area where there has to be the footprint, and the TL canal has to be in relation to this posterolaterally and the anteromedially. These are the
Roughly around
landmarks.
17 to 18 millimeters you would go from the anterior horn of the lateral meniscus.
So first of all, we build the tibial tunnel, the TL tunnel. So this is my footprint. I will place this posterolaterally. So I had a long discussion with Dr. Rob Laprade last year.
Recording in progress.
Last year when I was there in August for an advanced course, category course. So I asked him that you have been advocating, anatomical reconstruction as far as PCL is concerned, MCL, PLT. Why this stepmotherly attitude towards the ACL? And then I showed him my technique of double bundle, which I learned from Freddy Fu. And he said there are a lot of technical errors while doing double bundle, but if you are able to achieve good results, you keep on doing it. So I was quite, felt very happy when a person of that stature, approves your technique. So this is the PL tunnel that we have drilled, and now we change the angle. This was at 65-degree angle, and now we change the angle to 55, and we'll make the PBL tunnel for the AM. Now this is the AM tunnel that we made. This is the footprint. Just below this, you can appreciate the footprint.
So what is your sequence, sir? You usually drill the tibial tunnel and femoral tunnel, then you will go ahead with the meniscus repair?
No, we will drill the tunnel, and then I go to the meniscus repair, and then I find the
Okay. So I think you do the tibial tunnel as well. So and you'll how do you plan to prevent the fluid extravasation?
I am not very happy with this AM tunnel, so I'll just modify it. This should have been a bit laterally.
Okay.
It's a bit medially, so I'll just
change it.
Yeah. Because restoration of anatomy is the secret to success.
Absolutely.
So, 2 millimeters here and there, they can make a difference. So this was just 1 or 2 millimeters, but I think we can modify.
So, which graft you are using and what are the sizes of those grafts?
We are using hamstrings and triple 70. We are doing triple 70 for the AM and again triple gracilis for the PL.
Okay, and diameter square?
Diameter we are just AM is 9 and 6. So that gives a total diameter of 15. So closer to the footprint, which is about 17 to 18.
Okay. So triple 70 gives a diameter of 9. That's good.
He is a good, robust player.
Okay.
Or maybe people in Patna have bigger diameters. It's coming there only, but no problem. We just divert our drill a bit.
Okay.
1 or 2 millimeters, we can manage that. Because now one part has already become so, I don't want to. So it should have been a 1 or 2 millimeter more laterally,
Okay.
which we will adjust while making the tunnel. Now coming again to some very important point on the femoral side. Can I have this flow please? Flow. So very important is So very important point is how to recognize this over the top position.
Yes.
So over the top position is very important, especially for beginners. They misinterpret the resident rate. This is the resident rate. So they misinterpret for the over the top position.
Okay.
In this particular case, you have to clean a lot to make the over the top position. So this is the over top position. Is already reading the AM. So एक मिनट just पानी थोड़ा सा है. Water is पानी को just 1 minute. So this is the over the top position and this is the intercondylar of the resident ridge.
Okay.
Now the important thing about the ACL is that ACL has to be below this residence ridge. So this is the residence ridge, this has to be below this.
Yeah.
So the femoral tunnel AM will be somewhere here,
Okay.
and the PL will be somewhere here.
Okay.
But the important thing is they have to be below the resident ridge.
Yeah.
And there is a bifurcate ridge here which separates these two bundles. I am not able to appreciate that very well. But this is somewhere the area. This is the area where the bifurcate ridge.
Okay.
So this understanding of the anatomy is the key to success. So many a times in our earlier days when we started the ACL, many of our tunnels were anterior.
Okay.
And that is one of the commonest for failure of ACL, because if you make the tunnel anterior, then the graft will be tight in flexion.
Okay.
And is likely to fail. So I have still a good collection of lot of X-rays of those times where the femoral tunnel was quite anterior.
Okay. So your take on the footprint retention on the femoral side, sir?
Pardon, can you repeat?
So what do you prefer? You take down all the footprint on the femoral side to visualize all the resident region fiber?
Just to over the top position is important to visualize.
Okay.
To that extent, whatever soft tissue debridement has to be done. Otherwise, we try to retain the footprint, but only thing is we have to reach the over the top position.
Okay.
So now we are drilling the AM tunnel with 9. With 9, we have already drilled it with 6. So sequential reaming, yes. And so that has been reamed. Now just clear this tunnel a bit. So while reaming, the tunnel was diverted a bit laterally.
Yeah, we can appreciate that.
Can I have the shaver on? I think the mount of the tunnel must be clean of all soft tissues, and one can pass a device and then so that the flaps get raised, and then if you don't remove it, this can become cause for cyclo-obstruction later on. So all these flaps, cartilage flaps, must be debrided. So now you can appreciate the tunnel quite well. The edges have been freshened. Yeah. So that there is good healing from tendon to bone healing. Okay. So this is the end tunnel. We are still to make the PL and there will be a 1 or 2 millimeter of bridge between them. Now at this stage, we turn our attention to the femoral side. Yeah. And as I showed you the landmarks, I'll just clean a bit more so that you can all see. Shiver, please.
Sir, how to prevent the tunnel collision, both the tunnels, and what are the tips to prevent the anterior blowout for the large
Anterior posterior blowout is much more common. Anterior blowout. So important thing is this. I'll just show you. Now you can use the offset device 7 millimeter, but now we have become used to doing it manually and eyeballing. So I'll just show you how. First you put your drill here and you palpate the over the top position. I palpate the over the top position and then I come about 7 millimeter anterior to this.
Sir, this is standard anterior medial model or the accessory one?
This is my standard. Earlier we used to make इसे बेटा flex कर लो, knee को flex कर लो आप. Slowly keep flexing. हाँ. एक सेकंड इतना नहीं थोड़ा कम करो. Just I'll go again. I have to, I think, clean up the wall a bit before I attempt to do it. Just give me a shaver, please. So one way is to do by using an offset for the AM or the eyeballing method that we usually do. So occasionally this limited knot plasty has to be done just to clear your anatomy and to, otherwise one tries to retain the footprint as far as possible. थोड़ा पानी का flow बढ़ाओ. Yes. Now it is better. So this is the over the top position and I will go about 7 millimeters. So now flex please. Flex. Keep flexing. Yes. Go. I'll just hammer this drill a bit so that it gets a hold, purchase in the bone and then थोड़ा सा सीधा हाँ चल. So once it gets a purchase, then we drill this. Very hard bone. Yes, now we can drill it. Chalo, please go. So now we'll measure how much the drill goes inside. Yeah, and accordingly, set the length of our tunnel and the graph.
Yeah. This spade drill bit makes your life a little easier, isn't it? You don't have to do the 4 mm drill over it. And you can also measure it from
we try to measure the length, total length. But I think this tunnel, you have to change the trajectory, otherwise, can I have a spinal needle please?
a little more, I think.
Yeah, it has to go a bit more obliquely, otherwise the tunnel is coming very small. So we are just changing the portal a bit inferiorly so that our trajectory becomes more acute.
Okay.
Yes. Now flex it. Now flex. So our trajectory has become now more acute, and now I think our length should be okay.
Okay.
Pani, pani. स्ट्रेट करो यार, इतना इतना ज्यादा मत आप फ्लेक्स करो, सीधा कर लो, सीधा, जस्ट सीधा करो, हाँ, जस्ट पुट दी गाइड्स ड्रिल अगेन. नाउ गो स्लोली, फ्लेक्स करो बेटा, धीरे धीरे फ्लेक्स करो, करो 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 करो, थोड़ा सा, चलो बस, जाओ.
Yes. So I think it's important that your bead pin should come as perpendicular to the medial surface of the lateral femoral condyle as possible. And for that, if you need a far medial portal, you don't need to hesitate to make a new portal, isn't it, sir?
Yes, yes, yes.
So,
हाँ, हाँ, so this is about 28. So we build the tunnel till about 20.
okay. So you ring 9 mm here, anteromedial?
Yeah, 9 AM for that is for the AM.
Okay. Are you a little more posterior to than what you would like, sir?
No, when we drill the tunnel, we'll show you. I think
Okay.
we are okay.
Okay, sir.
Because we are making two tunnels. Na? In AM,
Yes,
you
sir.
can, if you are making single bundle, then you can be a bit between the two tunnels,
Okay.
AM and TL. But no way, everyone. So we have reamed the AM.
Yes, sir.
Can I have the shaver, please?
So removal of this debris is also very important, isn't it, sir? At every
Just
stage.
shaver, please. We'll just clean the edges of this tunnel,
Yes, sir.
and then now you will use a 5 mm offset to make
Okay.
the TL tunnel.
Okay.
Chalo. Yeah, silent.
Yeah.
Hello, leave it.
So for TL you use the offset.
Just 1 minute. This is a new setup, so
Okay. Take your time, sir.
इधर से जाओ. ठीक बड़ा था. Just 1 minute. Actually, the type of instruments being provided, we are not used to some of them. So this is the offset.
Yes.
And I insert this in the tunnel and now for hyperflex of that. Yes. Yes. Bus.
That offset is from the tunnel, is it, sir?
From the AM tunnel, yeah.
Okay.
We are using AM tunnel as a guide.
Okay.
So the idea is that there should be 2 mm wall between the two, and we'll ream till 6 mm. So that will make a wall of
2 mm.
So any difference in the knee flexion among during doing the AM and PL tunnel?
Pardon?
The knee flexion angle is it same
Yeah.
during the
Because
tunnel?
90 degree for the AM and for the PL, we have done about 120. Maximum flexion it is possible. थोड़ा पानी पुश करोगे छः का रिमोट. So for this PL now again we are going to ream with the 6 mm.
Okay.
Sir, is there a difference in the trajectory in which you drill the tunnel as well, the angle?
Yeah, this we have done maximum flexion, so that changes the trajectory so that the tunnels don't converge. So sometimes for this particular tunnel we are not able to see inside, so we measure from the outside. Because with that much flexion, the synovium and the tissues, they interfere with your vision. So we are seeing it from the outside and we drill till 20. So we will drill till again 20 tunnels. So now we will pass the ethylene wire to this. कोई बात नहीं, ऐसे ही डाल देते डालो. So we have to change the wire because that didn't have a eye. So anyway, so we are passing the loop. So this is the tunnel.
Okay, sir.
See that?
Yeah.
That is the PL, that is the AM.
Okay. So that covers almost the entire footprint area.
That will cover the whole footprint of the ACL.
Okay.
The retriever grasper could do. So now we are in the TM, tibia.
Okay.
And as you can see, there is a 2 mm wall here also.
Yeah.
Between the AM and the. So this is a bit more exacting surgery. There is no scope for error.
Yes.
So now at this stage, इसको बांध दो वापस. Now at this stage we go towards the meniscal side, just rest please, golden rest.
Have you passed the AM suture as well? AM bundle suture?
No, AM will pass later.
Okay.
Otherwise there could be lot of entanglement, so that we don't want.
Okay.
So this is the under surface
Yeah.
tear. You can appreciate very well. I think this will require just 2 all inside ankles. We are just freshening it. It's a good area, red zone, and we hope that this heals well.
Okay.
So we'll apply on the under surface. The plan is to insert one part of the ankle here and one on the under surface.
Okay. So both the sutures will be from the under surface only.
Yes.
So are you using the 15-degree up or angle or more?
Yes, 15 degrees. These are not going at the correct angle.
Okay.
In that case, I think just try once more, otherwise we'll go up and look. Cannot get a, we have to get a good angle.
Yes. Do you want to bend these are flexible one?
Just 1 minute.
Okay.
Let us see, we have changed the portal.
Okay.
Yeah.
Okay.
One we are going down now.
Okay.
So sir, you are giving vertical mattress type of stitches here?
It's a vertical mattress.
Yes.
Vertical configuration has the most stable configuration. Yeah, so one suture is gone, maybe one more. Get one more ready. We'll just tighten this and cut this suture.
Okay.
So one more. Yeah, we'll go just at a distance of 3-4 millimeters, more medial.
Okay.
Yeah. Now the other on the under surface. No, this has gone on the undersurface and we'll just tie this.
Okay.
And I think that should be sufficient.
Sir, do you always repair this type of incomplete here in the red-white zone? Or if it's
We try to repair whatever possible to repair, especially these undersurface tears. We have seen that if we don't repair them, they progress, and then few patients came to us with a full thickness tear. So it's better if there is some mobility in it, so that is not 100% stable. So in such scenario, we repair it. So just show me the probe. Probe, please. So now I cannot, pull it inside. So this is stable now. It's a bit inverted, but with motions, this will settle down. So now we are coming to the passage of graft. First we'll pass the PL tunnel.
Okay.
Both you are using the adjustable loop for both?
Yes, both adjustable loop of optics.
Okay.
Sir, what is the sequence of graft pulling and fixation?
So first we'll pass the photo. So this is the button. We go see it under vision going outside.
Yes.
So that it flips. Yeah, it has flipped. We'll just counter check it by pulling on the graph. Yes, it has gone. We are satisfied, and now we'll pull the rest of the graph and shorten the graph.
Okay.
So that PL graph is in position.
Yeah.
The fourth is. Yes. Taken. So it has gone. Now we'll put the AM. Yes. Yes. Circulates. So we keep the same degree of flexion which was there while reaming.
Okay.
And then we just from see that. Let's so now the beam thickness come outer side of tire.
Okay.
We are again going to pass a wire. Can I have the retriever ready, please? दे दो. चल सीधा कर दो बेटा. नी को सीधा को मेरे हाँ. So we have retrieved the aim.
Yeah.
And so we are in the tunnel, we can see.
Yeah.
So now we are ready to pass the ground.
Okay.
Well done. Yes. So we again want to railroad the graph. Yeah.
So what's your take on the fiber tape, these inverters, adjustable loop?
In majority of the situations, we do add an internal brace.
Okay.
So this has split, the button has split,
Okay.
and now we are going to pull the graph. I'm just going to pull the graph up.
Okay.
So this AM bundle is also in position now.
Yes, sir.
So now you were put out here, flip okay. So now the last step which is left is now the tightening of the tibial side.
Okay.
So can you focus outside now, outside image?
Yeah, we can see the outside limit, sir, but it's a little small. So can
Pocket please, pocket.
Yeah.
So light दिला दो, light focus करो इधर. So now first I will tighten the PL bundle.
Okay. At what degree of flexion, sir?
So this will be in full extension. So
Okay.
I cycle it couple of times to take away whatever little slackness is there in the graph.
Okay.
8 to 10 times. Then I position my knee in full extension.
Okay.
And then we are ready to use an interference. So we'll use a size 7 by 23. 28, sorry, 7 by 28. खोलो जल्दी. अगले के लिए पहले बोल रहे हैं. So we can go one size above or two size above. Since this is a very hard bone, we are going just one size above. So we are green with 6 and we'll be using the 7 Okay. So can you retract please? Show in the mouth. Yes, good.
Okay. Sir, do you use the post-operative X-ray? How do you follow them, these patients? And what exactly you will looking in the post-op X-ray?
Can you just repeat please?
Sorry, sir. I mean, how do you follow these up? Do you do the post-operative X-ray? And what do you look in this X-ray?
Post-op X-ray we do on the next day just to ensure that our buttons have gone in the right position and the.
Okay. Anything else you wanted to see?
Regarding the tibial tunnel, we make the patient walk the same very day in the evening, and in this patient today he can maybe partial weight bearing, and since this was a very stable type of meniscal tear, from tomorrow once his pain subsides, we can do full weight bearing with the help of a crutches or later after a few days with a stick.
And any brace you advise?
Yeah, brace is there for about, in this patient would be for 4 weeks. It will be all individualized accordingly. I think in a root tear, the patient would have been non-weight bearing with brace there for 6 weeks. But this is a very stable tear, so we can just follow a normal protocol. Instead of 2 weeks, we do bracing for 4 weeks, knee brace.
Okay.
It's all variable depending on how strong fixation is there and how much is the motivation level, how is cooperation of the patient. So there cannot be a fixed rule for all the patients. So it has to be a bit flexible and individualized.
Okay.
Normally, what exercises do you recommend? How many times out of brace?
Day one we start with the ankle pumps, the static quadriceps, the glutes and the trunk muscle isometric, and gradually we initiate knee flexion day one only, and as per the comfort level we can go even till 90 degrees in the first few days, but when we have done a meniscal repair, we do not, force too much flexion beyond 90 degrees, so that, and we don't allow him to squat for about.
So these are non-weight
2.5
flexion.
Yes, pardon?
These are non-weight bearing flexion exercises.
Yeah, weight bearing in this case, like we will start very early. We do put them on bicycle training after 2 weeks. So they got bicycle. So as I said, each patient is different. How much weight bearing, according to that, there are those exercises. And so now I'll putting my scope just to have a final view.
Yeah.
Can I have a shaver please, just to...
So, can we have the inside picture please?
Yeah, I'm just showing it.
Yeah. No, in our picture we can't see it. So just this is for the, yeah.
The screw is a bit protruding, but it is almost till the mouth, so
yeah,
I think we can ignore that.
Okay.
Yes. So first thing is that we check extension.
Okay.
So there is full extension, which means there is no impingement, which means that our tunnels are anatomical.
Okay.
So that gives us a great sense of relief. And now next we check the tension. So that's the AM bundle and that's the PL bundle.
Yeah.
So important thing is that in full extension they are parallel to each other, and in flexion they cross each other.
Okay.
So we have correctly replicated the anatomy.
Okay.
And so we have already taken care of the meniscal tear, and this seems to be with good tension and anatomical. So I think I would like to thank the whole OT staff, the anesthetists, the nurses, the technicians, and my own team of Dr. Shiv, who makes my life very, very easy. For all these high-end procedures, multi-ligaments, you need to have a good colleague who is equally trained, and I am fortunate. Thank you very much. If there are any other questions, I am ready to take them. Otherwise, I will be coming there and you can ask any questions.
Yeah, okay sir, so a big thank you and a round of applause from the audience for the nice demonstration. It was an excellent surgery. So thank you Dr. Deepak Chaudhary sir and Dr. Shiv as well. Thank you. And all the OT staff and supporting staff of PARAS hospital.
Good morning, sir. Chairperson, please stay for a while. Please, Dr. Sandeep sir, may I welcome Dr. Sandeep sir for the next lecture. Decision making in the meniscal tear.
I think he need no introduction, but I need to mention that he is currently the Secretary of Indian Arthroscopy Society, and he, along with the Sachin sir, is working really hard to make this IS1 a success. And IS1 is getting, all the IS members are getting recognition all over the India. So thank you, Sandeep, and you can proceed for your lecture.
Thank you, Surita. Respected chairperson, my dear friends and colleagues. Greeting from Indian Arthroscopy Society, and I am thankful to Dr. John Mukherjee sir, Dr. Vikas, and Dr. Arvind Prasad Gupta sir for arranging this meeting in such a short time. So, greetings from Indian Arthroscopy Society. I have nothing to disclose. So, when we look at this meniscus tear, so these are the most common injuries which we encounter in our practice. And partial meniscectomy is one of the most common surgery, orthopedic procedure or orthopedic or arthroscopic procedure done. When you look at the pathanatomy, so meniscus is a crescent-shaped structure with a triangular cross-section. Fibers are circumferential, and then it is attached anteriorly and posteriorly with the roots, so which prevent the extrusion of the meniscus. And lateral meniscus covers almost 84% of the condyle, while medial meniscus covers 64%. The lateral is a bigger as compared to the medial one. And when you look at the vascularity, because that is of prime importance, because this vascularity only decides about the meniscus to be resected or repaired. So it is given by genicular arteries, and at the birth it is almost 50% of the meniscus is vascularized. And based on that, there are 3 vascular zones, like red, which is the most peripheral, then the red-white zone and white zone. So when you look at the pathology, so it is all the collagens are arranged in a circumferential manner. Most of the fibers are circumferential, then there are radial fibers. And as said by earlier speaker, the meniscus acts as a load sharing, and always it also gives congruity for the joint, and it provides the stability, and it helps in the lubrication of the joint. So in extension, almost 50% of the load is absorbed by the meniscus, while at 90 degrees of flexion, it takes away 90% of the load, and beyond 90%, all the forces are passing through the posterior horns or the roots. That's the reason importance of the root or posterior horn tears. So if you remove this meniscus, then almost 2 to 3 times increase in the contact stress in the joint. And when you remove only inner 1/3, still there is 10% reduction in area and over 65% increase in the stress in the knee joint. So more is the increased loss of meniscal tissue, more is the contact stress. And if you do, or if there is a root tear and if it is not addressed, then the knee can function as like there is a complete meniscectomy. So tears and zones, already earlier it has been pointed out. Clinical examination, there are these various tests. I am not going to go detail into that. The most important investigation of choice for this meniscus injury is the MRI, which shows us exact nature of this meniscus. And ideally, when should we do MRI? So what do you need to do when you are planning MRI for this knee? At the earliest is always better, because if you do not want to miss the trap meniscus or any bucket handle tear, and then if it is delayed, then plan of management may change. So that's the reason for doing the earliest MRI. Once you have done the MRI, how do we decide about the management of these injuries? There are 2 important factors related to patient as well as factors related to meniscus itself. So conservative treatment is usually RICE treatment, rest, anti-inflammatory, compression and elevation in elderly patients who has got arthritis, grade 1 or grade 2 tears, patients who are less motivated, the patients who has opted for non-surgical management. Tear is a stable or longitudinal type and less than 3 mm radial tears, and stable partial tears. So all these tears can be very well managed with conservative line of management. So that means there doesn't need any arthroscopy, no meniscectomies or no meniscus repair as well. So when you decide about this operative management, so when there is a surgery, so if it is a resection or repair, so this is a diagram from the Campbell where you can see if the red zone, so there is good chance of repairability. But as we progress towards white zone and then this radial flap or chronic type of tears, usually we tend to do resection for that. So longitudinal red zone tear, even though they are acute or even chronic, within less than 4 centimeters of the tear dimension, it can be very well repaired. So I am not going to go into the surgical procedure already discussed earlier. So partial meniscectomy is usually for radial type of tears. If there are flap tears, horizontal tears, complex or white zone tears, so can be very well managed with the partial meniscectomy. So in partial meniscectomy, the goal is to debride the tear and leave the stable rim. Whatever you preserve is very ideal, and results have shown that satisfactory results at the end of 5 years after partial meniscectomy. If you do debridement or a section of the lateral meniscus, there is a faster degeneration of the knee joint, as shown by the various studies. So when you do meniscectomy, what are the positive predictors for this meniscectomy? So less than 40 years of age, if alignment should be normal, very minimal arthritis, single fragment tear. So all these tears predict the positivity for this meniscectomy. So when you look at the criteria for meniscal repair versus partial meniscectomy, so less than 3 mm stable, recent injury, and patient is willing to return to sports after later time, and younger can be managed with repair. But if it doesn't fit in this zone, then these patients may need partial meniscectomy. Repair is usually more than 1 to less than 4 cm in length tear, red zone tears, vertical tear, patient less than 40 years of age, there is no malalignment and acute tear. And if you are planning to do any arthroscopy, ACL reconstruction, and you encounter meniscus tear, then it also needs to be repaired. There are relative contraindications like advanced OA, complex tear, poor tissue quality, ACL deficient knee. Which stitch should be taken? So as it was shown earlier in this live surgery also, so as we know that all the collagen fibers are oriented horizontally. So vertical stitches are more durable and they give good support. So where to choose which type of repair? So as in this image, whatever mentioned in the red, you can manage with all inside. Blue zone can be managed with inside out, and the anterior most can be managed with outside in. All inside reduces surgical time. There are no external incision, and very easy to accessible to each and every corner of the posterior horn. There are various devices used commercially available for the all inside repair, as we have seen in this live surgery. So I'm going to skip this video. Then inside out repair is usually sutures are passed with the help of cannula, as we have seen in today's lecture also by Dr. Arvind. And then suture is brought out of the capsule, small incision is made, then knot it tight on the capsule. So this is usually for the posterior horn repairs. They can be very well managed with inside out. And then outside in, if tears are more in the anterior part of the or mid anterior part, and even middle third tears also can be managed with the outside in repair technique. So I think we can cover this during the workshop. So I'll just skip this video by Steve Spalding. So this is the cheapest and best available. We can use non-absorbable suture material. The rule is always to put one stitch at millimeter, as very well shown by Dr. Arvind in his lecture of bucket handle repair. These stitches are more durable than the meniscus suture implant. So there are various techniques for all suture. So when you look for the rehabilitation, so when you are doing repair, so patient must wear knee brace and partial weight bearing for 2 weeks. If patient is sedentary worker, they can go back to their work in 1 week. Laborers usually 6 to 8 weeks. Athletes in not before 16 weeks. And at the end of 10 years, there have been studies we have shown excellent to very good results. When you do partial meniscectomy, sedentary workers can go back to their work in 1 week. Laborers in 2 to 4 weeks. Athletes in less than 6 weeks. And at the end of 15 years, more than 80% have shown good to very good results. So take home message: degenerative changes develop more frequently in meniscectomized knees. Longitudinal tears heal more readily than radial tears. Peripheral tears heal more faster. And repairing both meniscus and ligaments improve the outcome of the patient. Thank you very much. And the team from Indian Arthroscopy Society, from the first week of September, we have our annual conference. Do register and see you all in Lucknow for highest contribution.
Thank you, Sandeep, for the nice lecture. Is there any question?
Sandeep, you mentioned about the early diagnosis with MRI. How early? Because generally there is lots of hematoma after acute injury. So do you think that our radiologist can give you a very clear-cut diagnosis? Especially also the machine. I mean, lots of variations in MRI machines are available in good centers. There are very good quality of machines, but otherwise all primitive machines are available. So there at some point.
Correct, sir. Sir, early means it should be done at the earlier, that means within 2 weeks of the injury. So that is the time usually hematoma resolves. But you cannot just, like the main purpose of that is, you cannot keep them treating conservatively and ask them to do MRI at the end of 4 weeks or 6 weeks. Because if we are doing something about meniscus, then that result may depend upon the time which we have missed. But 2 weeks is the ideal time. Till that time, hematoma can resolve.
Generally what we are seeing that patients have come to my chamber also injury, same day MRI done, some diagnosis, where we get confused whether it should be reliable or not. Because the patient is elected to go for another MRI after 2 weeks. So that's why take-home measures should be there. What is your message?
So actually, sir, I mean, if you look into the meniscus injury and ACL injury, these are not exactly equivalent to the knee dislocations where you have the collateral damage, a lot of capsular damage. Okay, sir. So in subtle injuries where you expect the ACL or PCL injuries and along with the meniscus, I think the collection is not that much, and that probably the blood actually helps you in interpretation because the blood acts as a sort of arthrogram. So you gives if there is a fluid in there in between the meniscus, you can interpret it much better. I think you don't rely on the radiologist to interpret the MRI. You see the film, I think you will be able to interpret it much better way because you are seeing the patient as well. So you can corroborate along with the patient's findings right there in front of you. So I think it's very difficult to read the report and treat the patient based on the report. But as such, the ACL and meniscus are, you can advise the MRI as early as possible on the day one also, and you can interpret it much better. Yeah, of course. But subtle injuries like ACL, PCL or meniscus tear, not the knee dislocation. So interpretation of the capsular tear and the collateral ligament, it becomes a little difficult on early injuries.
And also it's the clinical thing. You see the patient. If really it's hematoma is there is maybe 100 ml, 200 ml, then definitely you will delay the MRI. But if many a case comes to you having hardly there is little bit of swelling with good range of motion, then you can definitely ask for MRI at the same day. But if there is lot of hematoma, then it's better to delay for 2 to 3 weeks. There is no problem. And Dr. Sandeep, just extending this question, repairing the meniscus at day 1 or repairing it at 2 to 3 weeks, do you think it's making hardly any difference? So this is the message. So basically you can ask if you think that hematoma is lot of hematoma, then you can ask the MRI after 2 to 3 weeks. There is hardly till 4 to 6 weeks there is hardly any difference. We have lot of new surgeon here, Dr. San. We know you can repair all type of meniscus, any complex. So what are the ideal conditions that is should be very practical for those who have started doing orthoscopy and think that if I do the repair, this will having success rate with very good percentage.
If patient is more than 40 years of age, even though there is bucket handle tear, I'll think 10 times before repairing that. But if patient's age is less than 40, then even though bucket handle is chronic, I will still give a chance to repair. So the age group is very important. Then chronicity of the tear is important, and what type of tear, that is very important. So tear which has got less than 3 to 4 centimeters length can be also treated conservatively, and tear which is more than 4 centimeters and also bucket handle type needs surgery only. You cannot just treat them conservatively. And 100% there is patient is less than 40 years of age, so there is no question of doing meniscectomy for that patient. So you need to see all the aspects. It is not just only how is the patient related also and meniscus related also.
Yeah, so it's multifactorial thing that help in deciding where you should do repair or whether you should do meniscectomy. Yeah, Dr.
So will you Sandeep repair that double bucket handle tear with more than 4 centimeters tear?
Yeah, that was done by me. It was wrong or it was right?
Dr. Sandeep, how do you augment the meniscus repair? If there is only meniscus repair, no ACL tear, how do you augment the meniscus?
Augmenting the means biological?
Yeah, biological augmentation.
So we can do marrow venting procedures. So with the owl, you can just do microfractures, even though you are not doing ACL, but near that non-weight bearing area of the femoral condyle, you can do multiple punctures, or you can do a fibrin clot also.
So what is the role of ultrasonography for diagnosing the meniscus repair? Do you have experience with ultrasonography?
I mean, you want to follow up this patient with
ultrasonography or
for diagnosis? I think for diagnosis, MRI is best, but I think if if you want to save the money, probably if you have a good ultrasonography or you yourself is good trained, then probably you can do the high resolution ultrasonography for following this up. But I think meniscus repair takes a long time to show in your imaging that it has healed. So maybe 1 year or 2 years it shows some signal inside there. So I think it's more of a clinical diagnosis than MRI at a 1.5.
Clinically, it is more important if the patient says that the pain has settled, especially the joint line, which has got high sensitivity and specificity, then you can very well say that it has healed. I would go back and do an MRI or a ultrasound just to check whether it has healed or not. But if they get repeated clickiness, repeated pain around the joint line, especially squatting and stuff like that, then there is a doubt and should revert to MRI. MRI arthrogram is even better if you can get it.
Okay, my question, my question is that like in the last surgery, there was an under surface tear which was not visible from the top surface. When you are trying to repair that tear, while we are putting that structure, so how is there any objective way to ensure that the needle has not, the implant has not been discharged on the top of the meniscus and actually on the far side of the meniscus at the capsule? Because we can accidentally, it happened that when you are putting the needle from down to up, it can, like the implant can discharge on the top also. So is there any objective way to ensure that?
So there are two things. One, these devices, they have got a scale. So you can set that. So it can be up to 2 centimeters. So 18 to 20 is the length which usually we choose. Then various companies have got different angle devices. So like 24 degrees or 12 degrees. And some, they come with the flexible. So you can change your angle. So depending upon that, where exactly is the...
When we are using that device, like a 12 angle device, and we have set the distance to around 15 millimeter from the area, from the market. When we are just putting the first bite, it can accidentally come on the top also. Now we are trying to move parallel to the surface of the meniscus to the outside of the meniscus. But it can accidentally pierce the meniscus and come on the top surface also.
Yeah,
so is there any objective way to ensure that this doesn't happen?
So that's what, the trajectory and direction is important. Now if you mention 12 degrees, then there is no point in setting 15. It is like choices between 18 or 20. So when that comes, that is when you are repairing lateral meniscus posterior horn or very close to the lateral meniscus where you know there is chance of, then that time you can set 15, 16 or up to 18. But other place you can keep it even 20. So main aim is try and be as flush as, so that it passes or goes beyond the capsule.
Actually, you can always check with the scope. You can always have a look into the upper part after repair. Whether
Then again look at the top. Then
yeah. What's the problem? You can just take out your scope and put it on the upper part.
Yes. Actually, I wanted to say something on that checking ultrasound or MRI for meniscus repairs. So, what is literature says and what I have seen in my cases also, you keep seeing the signal changes even after 1.5 years of meniscus repair, and the patient is asymptomatic. So it is very difficult to actually tell that whether your meniscus has healed or not. And even the literature says that the actual rate of healing is close to 40 to 50% only. And if the knee is stable, so the patient is not symptomatic. So actually, I don't think by ultrasound or by MRI we can actually document that our meniscus has healed. If the patient is asymptomatic, no joint line tenderness, then we should take it as a healed meniscus.
So with a stable knee, even partially healed meniscus is equally good as completely healed meniscus. And about the meniscus repair, just for the beginner, there is rule of 4. Less than 40, 4-week-old injury meniscus, 4 centimeter, stitches should be at 4 mm of interval, and 4 prick if you are doing pie crusting, 4 prick so that your MCL is don't get damaged, and also the 4 micro fracture to enhance the biology. So remember these principle of 4 for good repair of your meniscus. Thank
On
you.
that note, Dr. Arvind, there is a paper from Coimbatore by Dr. Rajan et al. Which has given guidelines about when to do meniscus repair. and they came out with modification of that criteria, which I actually happened to edit and should be out somewhere in July or August. So previously the criteria was up to 40 years, now they have revised it to 50 years for repair, and there are few other things like age, chronicity and things like that. So it is a very good article to read in Journal of Indian Journal of Orthopedics, which should be free online as well.
Yeah, absolutely right. One of my junior, Dr. Vivek, is in that group. So thank you, Dr. Chanda sir. You want to?
Is there any role of CT arthrogram of knee in meniscus tear? Because some of the patients have claustrophobia. They can't go for MRI. Anyone?
Never done.
Google says that there is role of CT arthrogram in knee pain when there is meniscus tear.
So I have had experience with ultrasound, but not with CT.
No, but it is a small one for a very little time. And claustrophobia, patient cannot go for an MRI.
I think the machine for the CT arthrogram is almost
The machine is coming.
But it is for a very short time. There is a literature by some imaging center CT arthrogram of knee to rule out meniscus tear. It says the patient presented with knee pain leading to a suspected chondromalacia peteca or a meniscal tear. The patient did not want an MRI due to severe claustrophobia. Therefore, a CT arthrogram was performed. Fluid injected into the knee appears bright white on the CT below. This shows the musculoskeletal radiologist to evaluate for a meniscal tear or chondromalacia.
You the answer.
No, I was just asking what is the present trend, whether people are going for, because CT scan is very cheap, MRI is very costly also.
CT arthrogram is very cheap.
So I think
My CT scan in my hospital is only CT scan in my hospital.
Sir, we can continue this discussion over the tea time, and there will be a lot of interesting responses. Thank you, sir, for a nice talk.
We are moving to the remaining felicitation part. Dr. Sunil Hazra, please come on the stage. NK Singh sir, can you felicitate Dr. Sunil? Next, Dr. Ritu Gavli, please. Dr. Amulya Singh sir, can you felicitate? So next, we are moving to the inauguration ceremony. So Dr. John Mukhopadhyay sir, Dr. V.K. Sinha sir, Dr. Amulya Singh sir, Dr. S.N. Saraf sir, Dr. S.P. Gupta sir, Dr. Manish sir, Dr. Chanda sir, Dr. Jivendu sir, Dr. Thakur sir, Dr. Basir Anand sir, and all the faculty, please come on the stage.
सर्वकार्येषु सर्वदा लाल विराजे सुत गौरी हर को हाथ लिए गुणदंडु साई सरोवर को महिमा कहे न जाए गात कहूँ पद को जय देव जय
Thank you all. We'll take a short tea break here, and after that we'll start with the ligament session, that is session 2.
Please kindly come to the seat. So this will be the session 2 on ligament session, and the chairperson for the session will be Dr. Sandeep Biraris boss, Dr. S.N. Saraf sir, Dr. N.K. Singh sir, Dr. Amulya Kumar Singh sir, and Dr. Prabhat Prakash boss. Please kindly come to the stage.
Amulya sir, yes, we are waiting.
Announcement for everyone. Please come to the seats. Dr. Sandeep, Dr. S.N. Saraf sir, Dr. N.K. Singh sir, Dr. Amulya sir, Prabhat boss, and the first speaker for the session will be Dr. We have a slight change in the program. The first session will be by Dr. Deepak Chaudhary sir, and he will be talking about ACL reconstruction. Where are we today?
Thank you, Chairperson, sir, Dr. Upadhyay, and the members of this august gathering. Thanks for adjusting my lecture. Over the past few decades, the ACL surgery has become quite reproducible and predictable, and this is because of the better understanding of the sciences behind the ACL as far as anatomy, biomechanics, better implants. And all this has resulted in a renewed interest, and there are certain controversial things also, but all these things have added to the flair around the ACL reconstruction today. So I will be covering the following topics briefly: anatomy, biomechanics, how to make a clinical radiological diagnosis, a video of the anatomical based ACL reconstruction that you have already seen, and somehow I will touch some of the controversies in ACL and how to improve the outcomes. So we all know the anatomy of the ACL from the work of Freddy Fu, that it has got two bundles, the AM and the PL bundle, and they have got reciprocal action in the sense that the AM bundle acts mainly in flexion and the posterolateral bundle acts in mainly extension and provide rotatory instability. These are the footprints on the femoral and this on the tibial side, and we try to recreate the anatomy as you could see in the live surgery today. So again, the two bundles, they are parallel to each other in extension and they cross each other in flexion. And this is the intercondylar ridge that I was talking about. The ACL has to be below this, and the AM bundle lies behind and the PL bundle in front. So this is a very small area, and you have to recreate the anatomy, and the error chances have to be minimal to obtain or optimal result. So we all know AM bundle controls anterior translation and the PL bundle controls rotatory instability, and especially while the extended position. So clinical diagnosis, it could be a high impact injury in road traffic accidents, or it could be a low impact during various sports trauma. Basically it's a rotational force on a flex bearing knee, and the symptoms are usually of giving way and the associated symptoms of meniscus tear or the associated ligaments. So again, the clinical testing is very important, the outdoor, and the Latchman test is the most effective test that we commonly use. And however, if the Latchman test is strongly positive, one must suspect associated tears like root tear, deficient medial meniscus, RAM, or associated ligamentous injuries. Again, pivot shift, if it is very explosive, one must think of root, RAM, PCL, MCL. So one must develop to look for other associated instabilities and other injuries to achieve the best clinical outcomes. Again, the medial-sided injuries, they are often missed, and one must test the stress testing, the valgus testing for the medial side, and the various testing for the postural lateral knee corner injury. Again, assessment, many of the cases of ACL are associated with PCL, and if you fail to recognize this, it can result in a posteriorly fixed knee and will disturb the biomechanics and the kinematics of the knee. And this posterior draw test is usually performed, but the stress X-rays are much more accurate in the sense that less than 8 millimeter it indicates a partial tear, 8 to 11 millimeter posterior displacement indicates a complete, and more than 12 indicates a combined injury, usually with an associated PLC. Again, X-rays I won't cover. This is a case where their ACL is torn and patient has a bucket handle medial meniscus. Again, as we said, valgus test X-rays must be done wherever you are suspecting a medial side injury, and if the opening is more than 3.2 millimeter, you suspect a complete MCL tear. Again, varus test X-rays, the cutoff point is usually 4 millimeter, and if it is more than 4, you suspect a complete postural lateral corner injury, and you must reconstruct that also in the same setting. So anatomical ACL reconstruction we have seen today, it is the restoration of ACL to its normal footprint area, and it replicates, advantages are it replicates the normal anatomy, restores kinematics and protects long-term function of the knee. This is a surgical video of this is a revision case of ACL. This patient was then somewhere outside. This is a doctor who came to us, and as you see, this has already been covered today. So 2 tunnels on the tibial side, 2 tunnels on the femoral side, and correct placement of the tunnels is the key to success. The distance between the 2 tunnels on the tibial side, this is just a repeat of whatever you saw. And as I always believe, learning and repetition are 2 sides of the same coin. And again, 2 tunnels on the femoral side by eyeballing. The AM tunnel we make by eyeballing, but we have to remain below the resident ridge. That is very important, that there is a resident ridge or the intercondylar ridge, and one has to remain below. And then once you have made the AM tunnel, you use a 5 mm offset that we used and to make the PL tunnel. And if well made, there is usually a 2 millimeter wall between these 2 tunnels. So these are the 2 tunnels. You can appreciate there is a 2 millimeter wall. This is the PL bundle going inside, and this is the AM bundle now being pulled up. We usually add a fiber tape to the AM bundle just to augment it and tighten it in a slightly different tension level so that it acts like a seat cover, car seat cover, seat belt. And so this is the final picture. You can appreciate that this patient had a bucket handle tear also, and we used the all inside devices to repair this meniscus. I'll just fast forward this slide. So we completely repaired this bucket handle using these all inside devices, which work very well in our hands. So it was a long tear right from the posterior to the anterior. We changed the trajectory of our portal for the anterior most, and we could achieve a good repair using all inside. So this is the end picture. We sometimes validate our tunnels just to see that they are on the correct anatomical position, like in this case, and all the tunnels are anatomical. And this is follow-up MRI of the same patient, and 18 months you can see that both the bundles, the AM and the PL, you can very well appreciate, and the meniscus bucket handle has also healed quite well. And this is a 10-year follow-up of another patient of ACL, double bundle. We did a arthroscopy for a different cause, and you can see that both the bundles are there in good position, in good tension, and they have been vascularized, as you can see. So we have a long-term results for this double bundle, which is working very well in our hand. This is a 15 months follow-up of the same patient, and you can see him performing all sort of activities. He's also a doctor by profession. These are some of the controversies which I will briefly touch in the ACL reconstruction. Single or double bundle, again, it depends on your how good you are in your surgical this thing. And though the long-term results of single bundle and double bundle are various studies have shown they are equal, but in our experience, double bundle is superior to the single bundle, better restoration of anatomy, and the rate of re-tears are less, and it is more stable as far as our own experience of double bundle, which is about close to 2000. So recommendations for a double bundle to our mind is, it is not indicated for every ACL tear. Very small knees, arthritic knee, open physis, this is not the treatment for choice. Usually indicated in young athletic population engaged in competitive sports. It enhances the rotational stability, better functional outcomes at midterm follow-up, fewer graft failure. Again, the concept of ALL, it has come up again in a big way, and now whether to use it routinely or only use it in a revision situation or high-risk situations like female, hyperlex female, or a revision situation. So these are still under study, but the broad recommendations are that combined ACL and ALL give better post-operative clinical outcomes as compared to isolated ACL. It has a beneficial role in patients at high risk of failure, and patients in which we perform an ALL, they are associated with a reduction in ACL graft rupture rates. And again, another topic of controversy in ACL is the internal bracing. Though we are doing it in almost all the cases, again there are studies which show that it compresses the graft, but usually if you tension the fiber tape at a slightly different tension, we make it a bit loose, so it works. So the broad recommendations are that it functions basically as a safety belt for the new graft during the healing process, and it provides a viable treatment for the patients with the small diameter graft or highly active patients. And I'll take 1 or 2 minutes to finish off. And again, slope correction with ACL, this is another new topic. Usually it should be considered if the slope is more than 12, especially in a revision situation. Maybe in the first time, the slope correction may not be required, but especially if there has been a recurrence of ACL, so tibial slope correction is recommended if it exceeds 12 degrees, especially in a revision situation. This slope correction protects the reconstructed ACL. It is indicated in high-risk patients. So how to improve outcomes in ACL reconstruction? The correct patient selection. A young patient engaged in heavy sports and wants to return with good motivation level, that's the ideal patient. One must restore the anatomy whether you do a single bundle or a double bundle. The rehabilitation has to be individualized according to what you have done, whether you have attained a stable meniscal repair, how are the collateral ligaments you have reconstructed correctly. So all these, and one must treat the associated injuries, meniscal repair, cartilage restoration, single stage reconstruction of all the ligaments to achieve good results, and alignment correction wherever required. Sorry. So the take-home message is that the results of ACL are overall good, revision rates are quite low. Surgical technique is very important. Whatever technique you use, double bundle, single bundle, and operate better than not for some patients, especially in young active patients. And timing important, because if you delay too much, that can result in meniscal injuries, cartilage injuries, and must treat cartilage and meniscus also in the same sitting. These are the various how you can improve in future in the individualized surgery according to the patient's demand. Prevention of ACL, this is some of the new areas that need steady timing surgical technique. So understand every injury, every knee, every patient requirement and what they need, and we must treat individuals as individuals and not as a group. Thank you very much for your kind attention. Sorry for overstepping the time. If there are any questions?
No issue, sir. Thank you for your nice talk. Any question from Dr. Deepak?
Thank you very much, sir. We saw your surgical skill also and now oratory skill also. very basic question, sir. When you are going for double bundle technique, you are making two tunnels. How many chances are there that it will be converted to a single tunnel intraoperative?
No, this really happened in our early cases, and today also you could see on the femoral side there was some coalescence of the tunnels, but still in spite of that there was deep inside there was a break. So the coalescence as per se doesn't occur now, but yes, when we were doing it, we started these double bundles about 15-18 years back. There were a lot of chances, whether on the tibial or on the femoral side. So the recommendation is that don't attempt double bundle. People who are doing occasional ACLs, people who are doing high volume, maybe they can attempt, and only after doing it on a cadaver.
Right. Another question, sir. Is there any role of robotics? Because now robotic has come in arthroplasty. So any role, I don't know.
Maybe in future. I also not.
Sir, you have talked about the AL recommendation. AL supports the ACL reconstruction and results are very good. What you would take? You are doing AL reconstruction?
No, I was talking just to one of my colleague here. Actually, I have not done, to be very frank, not a single ALL. And this is what I was, arguing with my colleagues when I went to Chicago and with Rob Labrador and his colleague. Maybe because I am doing a PL, which has the same function of rotational instability. This has not come, I have never done an ALL. And even in revision situations, even failed double bundle, we have done again double bundle. And to my mind, that provides rotational stability. I have not done ALL, but again, there's a lot of people with experience in ALL who are claiming good results.
So you have also talked about the internal bracing. You are doing double bundle reconstruction. So you are doing for both bundle?
No, we are doing mainly for AM. And
what is reason behind in only AM, not the? because rotational instability most of the time controlled by PL. If you are going for the PL bracing, that is more, I think, that is more biological than the functional than the PL AM bracing.
Perhaps you might be right, but so many financial concerns. People want to do it. People come with so much knowledge these days, they want internal bracing to it. So we said, okay, we are doing it in the EM, but that is open to discussion. You are very right that we are doing it one by not the other also.
Sir, any comment on, sir, there is a procedure which has been mentioned, extra-articular penodesis, lateral ledge, so LET procedure. Sir, any comment on that?
No, all these procedures actually I have no experience. Maybe Sandeep, there are other experience. I have not experience.
From you would like to add anything?
What about LET?
Want to add sometimes LET to ACL session?
LET, in my practice, all revision cases. Yes, means almost all revision cases, if there is a revision ACL. But in cases of primary ACL, then I decide on table. If still there is a pivot shift after doing ACL, then I may add LET.
Actually, maybe grade 3 pivot shift, but in pre-operative. No, I never do this pivot shift after ACL because pre-operatively, if grade 3 latchman test is positive, grade 3 anterior door test is positive, grade 3 pivot shift is positive, or hyperlax athlete, not normal female, household female, hyperlax athlete is there. Even if there is no grade 3 pivot shift, I would like to add modified lemma or this LED procedure.
That is what he was saying. He is creating a posterolateral bundle separately. So he's saying that the possibility of
that is my thought and my experience. So I can be wrong, but since this is working very well in my hand, so I have not felt the need to do an open part when I am achieving the result with a double.
Right.
Thank you, Dr. Deepak Chaudhary. Thank you very much for your presentation. Now, may I call on Dr. Ravi Kumar for presentation. Dr. Ravi Kumar, please.
good morning. Special thanks to Arvind sir for the opportunity. I have a case presentation about ACL tibial spine avulsion, and I expect it to be a more interactive session. So, I had a case, 26-year-old male patient with almost 2 weeks old history of trauma. Patient presented to us with complaints of pain and swelling over the right knee, and clinically the lateral and draw tests were positive. There was no varus valgus instability. Following routine radiograph, the patient was having a tibial spine avulsion fracture, and there was a C-bone fracture, which is C-bone fracture. So coming to next, like, I just want to ask the audience, like, should we go for a CT or MRI, or both CT or MRI? Manish sir, what's your opinion? Should we go for a CT directly, or just CT or MRI, or both?
MRI can give you lots of information, but if you really want to go for the exact anatomy of the bone, the architecture, you can add on with CT. But MRI can give you information about the bone as well as the soft tissue.
So you only go for the MRI directly for the tibial spine?
I would go for an MRI.
Sir, Ramakan sir, what's your opinion for the tibial spine avulsion fractures?
My preferred doing MRI, because that gives lots of information, like apart from ACL, you can look for meniscus tear, other structures in the knee.
Yeah, it's MRI is the investigation of choice, but many a time, if any doubt about the PCL spine avulsion at the same time, or in between ACL and PCL, there is interspinal fragment also get avulsed. This is very rare, but I have couple of cases also. So to confirm that, you have to go for CT, but the preferred one is MRI, because this ACL spine avulsion associated with many a times root avulsion also. So this you will have in your back of mind previously, and many a time it's the complete dislocation, and X-ray is having only ACL spine or PCL spine avulsion. So all these information you will have before surgery, so that you will be ready intraoperatively for everything.
Arvind, don't you feel that X-ray showing avulsion fracture, it means most of the time the ligaments are intact? Because there is already avulsion fracture, so there can't be two injuries, both the soft tissue and
I'm talking about the remaining ligaments like PCL tear, LCL, MCL tear, medial meniscus, root avulsion. I'm talking about that. Most of the time ACL spine avulsion having ACL intact, but having said that, there is couple of cases that you might have, there is tear of the ligament also at the same time.
If you have to choose only one investigation, then
MRI is the preferred.
You'll be surprised at the number of times you have additional injuries apart from the avulsion of the ACL attachment. You could have, we've had patients with osteochondral fractures, etc. And so I think you need to investigate them. MRI would be, if you already diagnosed as an avulsion of the spine, then I would do an MRI first. If you really need to look at the bony anatomy, then CT. But it'll be surprising at the number of times you have additional injuries apart from the avulsion.
simple advice is MRI with CT cut.
The same thing I would like to say. See, my radiologist, I always tell him, actually it's in our routine. Whenever I ask for an MRI, either for shoulder or for any knee injury with some bony part, he always takes a CT cut and then he reports. So nowadays, if you are sending for an MRI, always ask him to take a CT cut. And that is the best way.
MRI with CT cuts.
Yeah, and they won't charge any extra also. They do the same charge. That's the best part.
In this case, we just got the CT scan done, and we had this tibial spine avulsion fracture. And one of the most important finding was that there was a large chunk of the bone. There was no comminuted, no fragmentation. So we decided for arthroscopic fixation with the Arthrex mini tightrope. For the tibial spine avulsion fracture, arthroscopically you have a suture lever technique. A lot of fiberglass can be used. But there is one, if there is a large bone chunk, then Arthrex has a mini tightrope, which is normally advisable for the ankle joint injuries. But we have used this Arthrex mini tightrope. It has a small 1.24 mm guide wire and just 2.7 mm drill bit. So coming to the intra-op, diagnostic arthroscopy was performed. We elevated the fragment. Since it was a fresh injury, always better to debride, just remove the clot and remove the loose fragments. Otherwise, if it's an old injury, better to just freshen up the bed. Reduce the fragment. Coming to reduction of the fragment, there are a lot of options. I would rather we use normally a footprint jig. Arthrex has a footprint jig. Rather than using a elbow or pointed elbow or a tip jig, we use a footprint tibial jig to reduce the fragment. And just rule out the entrapment of the anterior horn of the middle meniscus. That's quite often that middle meniscus anterior horn is entrapped in the tibial spine avulsion fragment, and that would not allow it to be reduced properly. So we need to rule out entrapment of the anterior horn of the middle meniscus. Then comes the intermeniscal ligament, and sometimes there is a anterior horn lateral meniscus entrapment also, but it's quite less as compared to the middle meniscus. So we have reduced this with the footprint tibial jig. Just hold it, hold the fragment. Important is that you have to put the jig on the posterior part of the fragment rather than coming to the center. So hold the fragment at the posterior junction of the fragment with the point of the jig, as the wire exits from the fingertip jig is mostly anterior. So this mini tightrope has a 1.24 mm guide pin. So just using the drill jig past the 1.24 mm guide wire, and they have a small 2.7 mm canuted drill. Important is that since the hole is just 2.7 mm, it gets tricky to trace the hole. So it's important to have a good exposure at the proximal tibia end. Once we have drilled with the 2.7 mm drill bit, then all is required is to pass this implant through it and just unlock it, and that's how it looks like after you unlock in the knee joint. Now next is whether goal is always for anatomical reduction, but do we have to go for over reduction or just accept the well-reduced tibial spine avulsion? Because invariably almost all the tibial spine avulsion fractures, they have an intrasubstance stretching of the ACL. So what happens is that over reduction can lead to excessive tightening of the ACL and subsequently limitation of the knee joint, knee motion. But long-term evaluation of the well-reduced tibial eminence fractures shows subtle increase in the anteroposterior knee laxity without any functional deficit. So all required is just reduce it properly, need not over-reduce. So that was the intra-op image of the patient. And this is the post-op X-ray showing the small button in the knee joint. The button size is very small, it's hardly 2.6 mm wide and almost 8 mm long. And this is a round button which is in the proximal end of the tibia, which is around 5 mm wide. Normally for all the tibial spine avulsion fractures, we keep the patient in brace locked in extension for almost 2 weeks, start partial weight from 2 weeks and knee movement from the 4 weeks. So this is the 2 months post-op follow-up.
Any question from Dr. Ravi?
Would you like to fixation like along with the knee tightrope?
It was good actually. We checked the fixation after tightening, after cinching it and tightening over the tibial leg.
The large size, small tightrope, and that straight size is very small. I think it's a single room.
Yeah, it's 2.4.
You have done both, right? Suture bridge and this. So you feel both are equally strong?
You can supplement it and put a better fixation.
So I just see the follow-up of the patient, just 2 months.
You reduced the fragment with that footprint jig, and then when you drilled it, it came out and it elevated. So you don't believe that you can put another K wire to just hold the reduction where we are drilling.
Important is that you have to press it from the jig. The jig keep it reduced.
So what's the results of when we remove the drill?
Screw fixation for these large fragments as opposed to tight ropes and all your fancy devices which cost a lot of money.
So if you go by the literature, the screw fixation results are comparable with the arthroscopic fixation. Both results are equal.
That's what I'm saying. So,
but there is just one risk of implant removal. Results are equal.
We have seen the fixation of a screw fixation also. Initially, people used to do by mini open, and it's very simple. procedure. Those who are not doing arthroscopy, they can fix ACL spine avulsion with very good chunk, very well with the S2 having equal results. But with the help of arthroscopy, only added advantage that you can explore complete to the knee joint. So if added thing, if it is there, then you can do that.
Still fix it with the screw.
Yeah, you can still fix with the screw. One, yeah. Yeah, 3-point chunk.
Yeah, I think, but sir, the biggest issue is these are rare cases, sir. Majority of the ACL avulsions are actually committed.
That's a different issue. When you have combination, then definitely there's a
Yeah, exactly, sir.
But if we talked about a single large fragment, that's a different.
So you do by single tunnel or double tunnel? Any single tunnel. Single tunnel.
Can we have a discussion later on, please? Actually, we are delayed already. Thank you, Ravi. Brilliant talk. And may I invite Dr. Sumit Hazra. He will be talking on anatomical ACL reconstruction. So, Dr. Sumit Hazra.
This morning we already had 2 double bundles, so I don't know whether mine is but
in between, I would like to announce NailsCon 2023 is scheduled at Rajgir 22nd to 24th of September. Those who want to get registered, please get it. And special attractive message for post-graduation students, you are getting a free accommodation there. So please get in touch with Dr. Vikash. That's all.
Thank you, Chairperson, and thank you, Arvind, for giving me the opportunity. I think ACL reconstruction, Arvind told me to show me 1 cases, but I think we all know that the majority of us are doing the single bundle ACL reconstruction. So very rarely, I think probably Deepak Sudhir is the only one who is probably doing double bundle in India, and 99.99% people actually doing the single bundle. I think the major problem with the ACL reconstruction is we want to do the isometric ACL reconstruction, where we don't want our grafts to get stretched. But I think with the biomechanical study, we know that there is no isometric point for the ACL. So I think this concept is very difficult to reproduce, and that's why what you want to do is more of an anatomic, where you want to see the ACL footprint on the femur. You want to see the ACL footprint on the tibia, and you can drill 2 tunnels on that. And probably one of the reasons why people are actually doing the double bundle, so they say that there is no isometric point for one ligament, so both the ligaments function separately, anteromedial and posterior. That could be one of the reasons, but majority of the people are actually getting good results with anatomical ACL reconstruction, which are supposed to be non-isometric, but might land up with a little bit of stretching. So I think for the ACL reconstruction, one of the biggest problem is where exactly in the femur the tunnel lies. So I think that is the biggest debate. So Bernard and Hurdle has shown that the anteromedial bundle lies a little superior and posterior, and the PPM bundle lies a little inferior and anterior. And by and large, majority of the arthroscopic surgeons usually follow this arthroscopic view, where the resident the tunnel is just posterior to the resident ridge and just above the bifurcate ridge, so where they want to reproduce the anteromedial tunnel majority of the times. And as far as the tibial footprint is concerned, we already have shown in the live surgery, it's a large footprint, but we tend to create the footprint on the tibial side with 2 or 3 reference lines, like the posterior border of the anterior lateral business, 7 mm anterior to the PCL, and the medial tibial spine base. So I think on the radiologically, if you see, the AM bundle usually lies 33% anteroposterior diameter, and the PL bundle lies at the 40 to 50% of the anteroposterior diameter. But what is more important is your entry border of the tunnel should be behind your improvement line in full extension, in full lateral view. So with this, I would like to just show this video, a small video. As you can see here, I usually prefer to reproduce the footprint both on the femoral side and tibial side. As you can see, if you go inside, then after debridement, the entire footprint area is visible. See, this is a large footprint area on the femoral side, and you should always debride the excess amount of ACL, but you keep the main footprint area intact, so that you can reproduce that ACL footprint paraportably. I think this is the back position, this is the front, this is the inferior part, and this is the main substance. So I think there are a lot of ways to how you do it. You can take the center of that footprint area if it is nicely visible, or you can use the offset jig, or you can use some freehand technique as well. This is the posterior part, is nicely visible. You can easily mark out the center of this footprint area, where exactly is it, and then you can use it all, or you can use the offset jig as well. So I usually mark out the center of the femoral footprint and then use an offset jig to stabilize the area, and then drill at the center of this footprint using an offset jig. So as you can see here, I am marking out that with the help of an bead pin or an K wire in the center of the footprint where exactly it is located, and then you can probably use an offset jig over it to stabilize that where exactly is you can look and you can mark the center of the tibial footprint, and then you can use the offset jig to So I think with this offset jig you can target that area where you have already marked, and you can then drill, because this offset jig gives you very nice stable fixation, and you can really target perpendicular to the medial surface of the lateral femoral condyle. So this is how you can drill them. I think the rest of the you can drill the bead pin, then 4 mm, and then desired diameter of the graft, whatever you have. So I think next is your now then you pass one sutures, and then you can have a see the entire footprint is visible from the area. That means you are drilled at the center of the footprint. So you see the posterior part also a little bit of fiber is attached, anterior part also the little bit of fiber is attached. Posterior wall is also quite thick. So that means that you have recreated the actual anatomy of the femoral footprint. And then you can drill your tibial footprint, and you leave a little bit of stump on the tibial side, and with the MR you can probably try the posterior border of the lateral femoral condyle, which should create just anterior to it, and there should be nice cover of the anterior ACL fibers. Don't debride all the anterior ACL fibers, and then within this bead pin you can over drill with your desired diameter of graft, with whatever you have prepared, and then this is how you, after you have drilled, you can see that the ACL fibers are covering nicely over the tunnel, and if you retract these ACL fibers, you should be able to visualize your nicely placed tibial tunnel. As you can see here, if you retract this, you should be able to push your scope inside and try to inside the tunnel. That your nicely located ACL tunnel on the tibial side is nicely visible, as you can see here. Okay, so I think this is how you need to reproduce the anatomical tibial and femoral side, and this will give you a nice reconstructed ACL. And then you should pass your graft. As you can see, the graft is being passed from the tibia to the femur gradually, and the graft is being milked into the tunnel. It's coming out from the tibial tunnel and it's going into the femoral tunnel. Nice robust graft is there, and as you can see, once the entire procedure is complete, your tibial femoral footprint should full with the graft, and your tibial side also it should be nicely covered with your tibial stem. This will give you nice coverage, and proprioception nuts will also remain there. So this is how your tibial footprint should look like. As you can see here, right at the posterior border of the lateral meniscus, and the entire ACL stump is covered with the footprint fibers. So I think the take-home message is for an ideal ACL reconstruction, the femoral footprint should be the best If you can reproduce it, other reference like the 2 millimeter wall, leaves of 2 millimeter wall and drill with the offset jig, and for the tibia footprint is also you try to preserve the footprint as much as possible. Remnant should be preserved for the better preparation, and the posterior word of the anterior horn is probably one of the best method for the reference for the tibial side.
Thank you, Dr. Hajra. Any two questions from audience side? So because we are running short of time, you can ask any two questions.
Question for beneficial to everyone. The position of the endo button on the outer cortex of the femur while creating the femoral tunnel, does it give you some influence regarding the anatomicity of the tunnel or the entry point on the middle wall? That gives you one form.
Entry point on the middle wall, there is no doubt about it, because the exit point depends on the degree of flexion which is there. So sometimes you may be able to achieve 130 for the very lean and thin patient, but in obese patient you can achieve maybe 110 degree flexion. So I think the exit point depends on the flexion. So
the take-home message would be that if the button is mal placed on the outer cortex, it doesn't mean it's not anatomical.
Yeah.
Thank you, Dr. Hajra. Our next speaker is Dr. Neeraj Srivastav. He will be talking on double suspensory ACL reconstruction. Dr. Srivastav.
Hello everyone. So we had enough talk about how to do an ACL reconstruction and all. So I am just presenting a normal ACL reconstruction with a different kind of fixation device. So classically everybody is using a screw on the tibial side. I have been using a suture disc on the tibial side. So I am just going to present how to use suture disc and why to use a suture disc. So tibial suspensory suture disc and rest all is same as it was presented before. So the advantage is that I have to take only a ipsilateral CMT in all of my cases. I need not touch my gracilis. I always take my CMT only, I quadruple it. So the minimum graft length which is required for a quadruple tendon is 24 centimeters. So 6 centimeter graft after quadruple is sufficient for a double suspensory kind of fixation. What you use for all inside kind of technique, it is same. The same length is required. Sometimes you get short females in which even 24 centimeter is difficult. So what I do whenever I am taking my graft, I always take a sleeve of periosteum which sometimes come up to 2 centimeters. So the length of the graft increases and I am okay with my single graft. So the minimum graft thickness which I always make sure after quadruple is 8 millimeter. Less than 8 millimeter is not acceptable in any of the patient because the strength of the reconstructed ACL is very low. If by chance the thickness is less than 8, which we see in some, especially in female patients, short female patients, sometimes we get minimum 7 only after quadruple, then you have to add your gracilis. So this is about the tendon preparation. I think everybody knows how to prepare tendon. So I am just coming to the next talk. Next video. In this patient I have to do collateral also, so I took both the CMT and gracilis. So in this I am showing that when you take both the tendons and you quadruple, how the size changes. So it is double gracilis and double CMT, what we call as quadruple hamstring graft. The size is 8 millimeter. Now in the same patient, I'll just make a quadruple semitendinosus graft, it will come as 9 millimeter. So the single most important factor for the strength of your reconstruction is your graft thickness. So how graft thickness actually becomes less when you take one more tendon. So it is now 9, you can see the same patient. So femoral suspensory fixed loop button, sometimes adjustable loop when I get a very long or very short tunnel. Table is always suspensory suture disc. Graft is pulled and tied over a suture disc. If graft is coming out of tunnel and if it is long, then this method of fixation cannot be used and you have to use a screw. This is how the suture disc looks. This is a video about how to tighten the suture disc. See, there is no tendon seen on the mouth of the tunnel. Okay? We always make sure that the one end is tight, so we are sure about the two ends of your ethibond. The graft is stitched with a 5 number ethibond in all the cases. This is a simple suture disc. this particular make is Smith and Nephew, but every company is making suture disc. Just you have to be very sure that the edges are not sharp, else they will cut your ethibond. If you are not very sure about your edges, then you have to take fiber wire for the preparation. So your assistant is pushing the suture disc with a screwdriver or any other blunt instrument. You have to give one knot. Always keep seeing that the knot is tight and the screwdriver is not pushing your knot, otherwise it will cut the ethibond. This is the first knot. You have to hold it securely, and after this first knot, your assistant will give a posterior draw over the knee and you will tie the second knot. So this is how the suture disc is tied. Somebody who is not doing it regularly might think that this is a very flimsy kind of fixation, but believe me, I am not giving long knee brace to any of my patients, and almost 12 years I am doing this fixation only, and nothing is failing. It is a very sturdy situation. If your suture disc is not tight, because you have to put an artery and see, it should create a sound like ton ton. It should actually create a sound. If it is loose, then you have to retighten the disc. For that you need not untie the sutures, you have to just rotate it. So this is the technique of retightening the disc. We even have papers on this. You just rotate it with an artery forceps 2 to 3 turns and it will not come back. Rest assured, it will not come back in your rehab. Just rotate it and the disc is tightened, if by chance it was loose. Now with other companies we have peak suture disc also, which is named as T-button, the free T-button, and a T-button with a loop. It is actually on the same concept of the surface fixation and using a single tendon. The only advantage is now you have a closed loop which will give you a very tight graft. So this is how we prepare with a T-button. We use tendon preparation like we do in all inside. We make a closed loop of a quadruple semitendinosus, and this is the cinching video of your T-button. So it is fitting on your tibia. So it is same rehab and same concept as the simple suture disc. Only thing is you have a fixed loop, so you can tighten this better. So this is the amount of tightening you get with surface fixation. It is never loose, and if it is loose, just rotate it 3 to 4 times, it will become tightened. This is how the X-ray looks in suture disc, and this is how it looks in T-button. The rehab is same as aperture fixation. The advantage which I feel we get with surface fixation is only semi-T is required and gracilus is spared. What I have seen in the rehab of my patient, if you actually leave the gracilus, the deep flexion is restored and your patient will bend the knees very fast, the pain is less and the graft size modulated is very less. You always get a thicker graft. Even in short females you will get graft minimum 7.5 to 8. Try it, it will be always good. No graft of crushing through the screw. If the screw is not very blunt, it might actually cut the graft. Fiber tape internal bracing, if you are very fond of this technique, then you can use fiber tape as a seat belt mechanism with the same fixation device. You need not add any additional device on the tibia for your fiber tape. Query better healing, this I have just put query because now we know that the healing is at the mouth. So if the screw is not coming till the mouth, the healing is better in screw also. We all face infection in few of our patients, and if I talk about the infection, we always see the infection on the tibial side only. Everybody would agree, one small sinus is there which will keep on pouring some serous discharge. So if your implant is at the surface, just give some local, open it, give some lavage and close it. So even in my case I have seen that the tibial side infection remains at the surface for longer time. The screw is inside, you cannot give lavage under local, you have to open it and the lavage will not reach inside the tunnel. But this is sitting over the tibial surface, so you can give lavage if at all your knee is infected. And the best part is, if you are revising a suture disc, then believe me, the revision of the tibial side is as good as the primary surgery, because you will find bone formed just beneath the suture disc, and you can just remove it and do a tibial drilling like a primary surgery in suture disc. Any question? If there is, we can talk. So that's like
tying a knot, you are taking two suture ends, both sides to the knee teleport, you have to put in the knot. So
the knot becomes thicker. What I have done the same thing, the knot becomes thicker. So how many times do you take the knot? Like if you are doing a regular time serpent's knot, we take full, then we reverse it, then again 2 full.
See, actually, there are two indications in which we cannot use suture disc. One is if the graft is long, and if your patient is very skinny, then better to avoid suture disc. You can use T-button in skinny patient also, but if you want to use suture disc, then better not to use, because he will be feeling the knot always, and he might come to you for knot removal. Yeah.
So
I take 5 knots always. 5 knots of Ethibond 5. It definitely gives a big knot, but in most of the patient is not bent. Skinny, don't use it. Go for T-button because there is no knot over it.
Neeraj, for T-button, since this T-button is having little bit stem,
the stem is there, which is 7 millimeters.
So technically your graft should be smaller in the tunnel, tibial tunnel. It should not be flush, I think.
We can cut the graft.
Once you have prepared,
when we harvested it, we'll cut it to 24
that's why I am telling you that technically you have to very perfect, very
I'll tell
ideal.
you, see, with T-buttons come just 2 years back. We developed only 2 years back. Before that, I was using suture disc. So suture disc I used to take maximum 7. With T-button, maximum is 6.5.
That's
If
right.
it is more than 6.5 in quadruple, then you have to cut it.
Yeah.
Otherwise, you cannot do it.
So you have to very calculative about this.
Around 6.5 does all the work.
Yeah, and many a time maybe if suspensory fixation, adjustable loop on the femoral side, so that if you think in the graft in the tibial tunnel is almost flush or bigger, so you can take the graft more on the femoral side.
If there is space,
Yeah.
if you have till later.
Yeah.
That is, so if the graft is coming on the mouth with a T-button also, use a screw. Cut the T-button, use the screw.
Would you be preferring Ethibond or a fiber wire for this?
Sir, I have been using Ethibond 5 only, and fiber wire is a stronger material, but since I have not got even a single trouble with Ethibond, I have not shifted to fiber wire. But if
5 number Ethibond, I mean, not, I mean, total opens up.
never open. More than 1,000 patients, never
If you are
open.
not considering
You tie 5 knots, it will never open.
If you are
Cover
not
it.
considering the strength, so you saying that fiber
Strength is less.
If we just don't consider it, even the knot will be smaller with a single fiber wire, na, because you have to use 4 strands of Ethibond.
I'll tell you. See,
With fiber wire you use just
fiber wire 2 you can use. It is stronger than your Ethibond 5. You can use. I'm not using because when I started doing, the fiber wire was not readily available. Since I'm not getting failures, I'm not shifting. That's it. Because fiber wire 2 is a better material. The knot will be thinner. Yeah. And even the rate is almost same. See, we developed T-button 2 years back. We have done a study about all the graft strength and the strength to breakage. So we have found that Ethibond 5 4 strand breaks less than 500 newtons, and a normal fall is 600 newtons. But it has not broken still. I am telling about a laboratory thing, because whenever the patient is falling, it may be after 2 weeks, because he will be walking normally after 4 months only, 4 weeks only, if you say unassisted stairs. So a normal fall will happen by that time. The graft must have healed something. So we are not taking account of the graft healing in vitro.
What will the post have precaution for this patient? If you are just putting
Nothing. No, see, I never give brace. We start range of motion second day.
weight
Weight bearing as tolerated. Many of my patients start full weight bearing without any stick if they are having good pain tolerance.
Thank you,
I'm
Dr.
not giving any brace and any sir.
Thank you, Dr. Neeraj. So, thank you for the wonderful talk. I would like to invite Dr. Arvind Prasad Gupta for his talk on biological augmentation of ACL reconstruction.
Dr. Sunit Bose and Dr. Neeraj, you have presented your ACL reconstruction. So even with the best reconstruction by best hand like Dr. Sunit and Dr. Neeraj, do you have failure of this ACL? And what is the percentage of that? So 10-15, Dr. Sandeep, it's 10 to 15%, maybe sometimes 20%. So still with the best anatomical tunnel with good diameter graft is the failure of the ACL. And at the same time, the biology is the most important factor. Almost 30 to 35% of the failure of ACL is because of biology problem. So here you can see the very good reconstructed ACL is there. But the biology comes from the remnant part of the ACL only. And because of this lack of biology, many a time there is tibial tunnel dilatation is there, femoral tunnel dilatation is there, and the failure of ACL even with the best hand. So my principle here is to repair this, the remnant part of the ACL to the femoral footprint at the same time. So Dr. Sunit has said that you should preserve the ACL remnant, but if you repair this to this also, this will give you the advantage of mechanical support. At the same time, the remaining biology will be much more better. So it preserves the proprioception function, accelerate the cellular proliferation, revascularize the grafted tendon, and there is low incidence of tibial tunnel enlargement. So this was the case 30-year male. Dr. Sandeep, you can see the MRI. What you can say by seeing this MRI?
There is a tear in the ACL and it looks like it is maybe like 2/3 torn. Some remnant is and some continuity is there. Some fibers are in continuation and good stump.
Yeah, good tibial stump is there and femoral, and it's the fresh injury. Only 3-week-old injury it was, and this was the coronal section, and this is how does this looks. So this is the intra picture, 3 weeks old ACL tear. This much of very good stump is there. And by looking the femoral side, you can see this is the femoral side, that is complete rupture. So in this case, the plan was to do the ACL reconstruction, at the same time augmentation of the ACL reconstruction with repair of the remnant ACL at the same time. So this was the femoral tunnel that as usual is tender that we have seen in the live surgery also, and Dr. Sunit Bose also have demonstrated very well. So this is the anatomical femoral tunnel. And the usually graft diameter in such type of cases where you want to do the repair of ACL at the same time, usually in between 7 to 8, not more than that. Otherwise the chances of overstuffing and impingement will be there. So here tibial tunnel was 40 and the femoral tunnel with the diameter 8 was made with 25. So after making the femoral tunnel, so this was the femoral tunnel. Here, this is the femoral part of this, and this was the fiber tag. This was the fiber tag that was used. This is 2.6 millimeter, usually used for the shoulder by Arthrex company. This is the cannula for insertion of that, and very low profile. This is the anchor is there, usually used for the Bancart here. So just behind that there is tunnel of the ACL, and for the repair part I have taken this fiber tag here, you can see, and this is the 2 thread of that, and with the help of this bite, this scorpion, just taking the bite in the remnant ACL here. So one bite is here. And this is the another bite. So this is before passing the your graft.